Hi guys, hope you're doing great. I think that every MCQ that you solve will make you one step closer to victory. And you don't have to, in every 1 hour that you're studying, it may not be productive, but then you have to show up every 1 hour because see, suppose in this 1 hour, if the productivity is less, maybe in the next hour, I can compensate by focusing more. So it is about like showing up every single day and every single hour, in my opinion, and your productivity will keep on fluctuating. Like we talk about the waxing and waning course for so many medical illnesses, I can say a similar curve can be present with respect to concentration as well. So my suggestion at the moment is that you're building yourself for a grand finale, and the next few days are gonna be a test of your grit and discipline that is gonna be put to test, and you are like standing on the edge of greatness, I would say. So with these words, I think we can get started for today. I would be just waiting for your quick comments in the chat box with respect to whether the audio and the visual part is perfectly fine, and then we can go ahead with our subsequent part of the discussion. We'll be focusing in this particular section mainly on the cardiology and the neurology component, which form the core with respect to the questions that come on general medicine. And just a word of wisdom here, that is like there are only 2 days in a year that we cannot do anything, that is yesterday and tomorrow. I mean, every single day we can be putting our best foot forward, and that helps in results in optimal results. So yes, guys, just waiting for a quick confirmation from your side, and then I think we are good to go for today. The main focus would be to do a bit of theory revision, as well as I'll be putting some multiple choice questions in between as well. So that would help you ace your skills both with respect to theory as well as multiple choice questions. So yes, CVS I'll be doing, guys. Thank you so much. And those, if you might be having any issues with audio, you can just close and go back to the video again, because sometimes there can be like a local relay issue as well. So this would cover all exams, guys. Even if you're sitting for FMG exam, if you saw the level of the last FMG exam, it was crazy difficult. So I think that I mean, we can focus on the theory part. The PDF of this would be available subsequently. I think they'll be sharing the links subsequently, and you can just register on that, and you'll get a PDF of the same. Okay, thank you, Dr. Sakshi. The session will be variable, doctor, depending on your, I would say, responses, that the duration will be decided. So we start with the, yes, doctor, I'll be speaking primarily in English only. That would be the major, mode of communication, except for a few, some in between words from the mother tongue. Otherwise, like it's gonna be core English aspects. Okay, so let's hit the comment button with respect to the first question for today, and I'll be expecting answers from you guys. Doctor, I'll let you know where to get the PDF. Like, let's focus on the core aspects at the moment. Like, let's not focus only on the PDF part, because it's more important to listen to the theory component. Okay, so we are having a patient who is having exertional dyspnea, 60-year-old man. He's fainting while dancing in a marriage party, and you are having a heaving apex beat, and there's an anacrotic pulse and a systolic murmur. And then I'm getting like a lot of varied inputs there, though I think Jay was the first one to mention. Jay Bora was the first one to comment on the correct answer for this one, guys. This is not hypertrophic cardiomyopathy. Hypertrophic cardiomyopathy will be presenting much more younger, usually between 20 to 40 years of age. And then in that condition, you will not be having an anacrotic pulse, but the pulse that is found in hypertrophic cardiomyopathy and has been discussed so many times is pulsus bisferiens. So I think you were able to identify the question right away on reading the word anacrotic pulse and systolic murmur. In fact, if you watch the movie Terminator, then Arnold Schwarzenegger, the lead guy, I mean, I think all of you, especially guys listening to here who love watching action movies, I think you would be like, Terminator series is like that gold standard thing with respect to action movies. And Arnold Schwarzenegger, Mr. World, he developed valvular aortic stenosis. And post that valvular aortic stenosis, he had to undergo a transcatheter aortic valve replacement. So the first and the foremost thing is, this is a very easy question that I'm starting with, so that I can help you guys get into that warming mode, just like athletes practice on a daily basis. First do their warm section and then they get into hardcore data. So guys, the diagnosis in this case based on anacrotic pulse and a systolic murmur is going to be valvular aortic stenosis. I have also explained the word SAD mnemonic for it, that there is syncope on exertion, there is angina, and there is dyspnea. I mean, SAD is a mnemonic to remember the manifestations of valvular aortic stenosis. Opening chota ho gaya na, sir? Can you comment? Can you quickly comment in the chat box what is the normal valvular orifice for the aortic valve? Normal is like approximately, yes guys. Normal would be like, about 2.5 square centimeter, and in aortic stenosis, anything less than this would be causing critical reduction in the blood supply to the aorta. So therefore, there can be development of syncope on exertion. There would be a concomitant development of angina, because the person would be having left ventricular hypertrophy, though in this question there is no mention of angina. But then, I mean, these are three primary reasons why these patients would be coming to us. And the highlight of this condition is that the murmur will decrease on standing. In hypertrophic cardiomyopathy, the murmur tends to increase on standing. The murmur of hypertrophic cardiomyopathy is totally opposite of all other murmurs. I've said that statement multiple times. I'll re-emphasize that once again. All murmurs decrease with Valsalva, standing, and amyl nitrate inhalation. The logic and the rationale behind it is that less blood would be coming in the heart. If the less is going to come in, therefore the intensity of the murmur will decrease. That explains answer as option number A for this question. And yeah, Dhanushri, you're perfectly right with respect to mitral valve paralysis, but there it is like longer, right? So one is going to be louder, another one is going to be longer. The gist of the first question is that don't assume answers to a question when it comes to option number B, C, and D. That is asymmetrical septal hypertrophy, banana-shaped cavity of the left ventricle, and propranolol. They are all features of hypertrophic cardiomyopathy, and this question can be ruled out on the basis of age. That's number one. And the second thing that I think you can be using to rule out hypertrophic cardiomyopathy is the pulse finding, which is pulsus bispherians. The ABCD of pulse is what I can say at the moment. Anacrotic pulse, bispherians pulse, Corrigan's pulse, and dicrotic pulse. I'll be writing the mnemonic of ABCD subsequently for the types of pulses. But a good job to all of you who got the scoring question correct. And now we would be you getting a hang of it. Let's move on to the next question, the second one for today, before I focus on the theory part. This is just a warming session so that I can get you all warmed up for the main session and the theory that we'll be doing. Okay, so we have this young female. She's having these palpitations and dizziness after playing lawn tennis, and she's had like such multiple episodes for past 2 years. And he says like, what would be the ECG finding? That would be, I mean, this particular ECG is signifying which particular condition. Okay, so yes, guys, a very straightforward. This is a repeat question from the INI-CET exam, and what you can pick up in the ECG of this patient is, I'll try to replicate it. I mean, in the V1, right? What you can see is a presence of a very deep SR, and then you can note that notching that is present before there is a T wave inversion that is coming. That notching that is happening is what is called as an epsilon wave. This would be seen in the terminal part of the QRS complex. So that helps you identify that this is going to be arrhythmogenic right ventricular hypertrophy, arrhythmogenic right ventricular dysplasia. Along with that, yeah, you can see a T wave inversion happening in all the leads, right from like V1 to V5. All the leads are having a very symmetrical T wave inversion that can explain the presence of a subendocardial ischemia in these patients. But if you look at all the options when it comes to, I'll just make it more symmetrical. Option number A, hypertrophic cardiomyopathy, will be having left ventricular hypertrophy. And for diagnosis of left ventricular hypertrophy, the depth of the S wave in V1 and the height of R wave in V5 or V6 should be more than 35 millimeter. And that criteria is not getting satisfied. I don't see deep S waves in lead number V1, and I do not see like very tall waves in lead number V5. So that would be ruled out. Brugada syndrome, well, that would be having that characteristic cove pattern of ST segment elevation, and I'm just going to draw that cove segment, cove ST segment elevation with a T wave inversion. In fact, Brugada will be having any of the two possibilities that I am currently making before you. One of them is called as a cove pattern, the second is called as a saddleback pattern. And since Brugada has already been asked in the exam in the previous year, so that can rule out option number C as well. You can see two types of ST elevation shown in this line diagram. That's going to be the first, which is called as the cove pattern, and the second one, which you can see, is a saddleback pattern, and this is a sodium channel defect. So prior to this in the paper, they asked regarding Brugada, which is a channelopathy, but in the recent paper, they decided to ask regarding ARVD. And as far as the details of ARVD are concerned, there would be saddleback is a feature that is seen with both 2 and 3. You are right. And co-pattern would be for type 1 Brugada, so the total of 3 varieties. And what is Uhl's anomaly? Then Uhl's anomaly is when there is no right ventricle, or there's a very thin, I would say, right ventricle. I mean, there is no myocardium in the right ventricle. So two very close differential diagnoses in this question are there. One is arrhythmogenic right ventricle dysplasia. Second is Uhl's anomaly. Uhl's anomaly means that the RV myocardium is not there. So patient will present in pediatric age group. Patient will not present at 25 years of age group. It would be a pediatric presentation with that of right ventricular failure. Because imagine if the right ventricle muscle is not there, only the endocardium and the epicardium are fused to each other. If you don't have muscle in the right ventricle, man, it's going to cause features of right ventricle failure in a pediatric age group. So keep that thing in your mind also, that if they give you features of RVF in a very pediatric scenario with absence of right ventricular myocardium, that's what we gonna get answer as that would change the entire domain of the question. So since we are having a younger patient at 25 years of age, and usually athletes nowadays, right, if they're having a sudden death, the reason for this can be arrhythmogenic right ventricular dysplasia. And what you mean by arrhythmogenic right ventricular dysplasia is what I show you in my subsequent slide. Yes, that is desmoplakin. That's the gene that they're gonna ask you, and they're also gonna give you a slide of this condition. So look at the peculiarity of the image that I'm showing you at the moment. This particular image is having a fibrofatty. This particular image that I'm showing before you is having especially the fat component. No, the fat part is much more visible. I mean, you know from pathology, the fat is washed off, so all those white spots are present. I mean, normally we see these kind of images with respect to a fatty liver, but what I'm telling you at the moment is that there is a fibrofatty replacement in the right ventricle. And because of this fibrofatty displacement in the right ventricle, especially in the area adjacent to the epicardium, you see epicardium followed by muscle. Epicardium followed by muscle. In the muscle, there is a fibrofatty fibrofatty deposition present, and this contributes to development of a voltage gradient. You can comment in the chat box what type of arrhythmias would be seen in arrhythmogenic right ventricular dysplasia. The name is ARVD, as somebody commented very rightly. No, this is not a tabby cat, doctor. This is not a tabby cat that we're talking. We are not talking about Naxos syndrome at the moment. Naxos syndrome would be having woolly hair and all those things. This is simply a patient who's an athlete. She plays lawn tennis, and she had multiple palpitations, and luckily she did not die. Otherwise, there could be an accident. She's participating in a lawn tennis rally, and due to the excessive strain on the heart, there can be a possibility of death in this patient also. Yes, one of the common one that is seen in these patients is this is a disease related to desmosome, so desmoplakin defect is one of the common ones that we see in this patient. But like the comment, I would like you to hit the comment button. What is the common arrhythmia that would be seen in this condition? So it would be a ventricular tachycardia, which is the usual cause of death in these patients. Ventricular tachycardia can then degenerate into ventricular fibrillation, but this slide number 1 that I've shown is for ARVD. And let me know what is the treatment for this condition as well. Quickly hit the comment button. I would like everybody to simultaneously hit the comment button. Tell me the treatment of choice for arrhythmogenic right ventricular dysplasia. The condition would contribute to sudden cardiac death. So I think absolutely. Beta blockers, I am getting ICD plus beta blockers. Okay, so in this condition, well, there would be no role of beta blockers. I would say the main treatment for this patient is to put in an ICD, that is implantable cardioverter defibrillator is the main treatment that would be required for arrhythmogenic right ventricular dysplasia. So it is implantable cardioverter. Doctor, it's not implantable pacemaker, right? Pacemaker is obviously for bradyarrhythmias, but in this condition, because there's a there is like a possibility of development of tachyarrhythmias, that is why implantable cardioverter defibrillator would be required. Then another very common slide that they give, and I think Madam would have also discussed it, that is going to be having that helter-skelter appearance of the myocytes. So this is very straightforward, the helter-skelter appearance, H for helter-skelter for hypertrophic cardiomyopathy. And then you can see hypertrophied myocytes. In fact, this is again a very big peculiarity, that if you find that some of the myocytes are damaged and some of the myocytes are going to be hypertrophied myocytes, because they give these integrated questions where you would be having some clinical domain and some pathological information present. So this is helter-skelter. You can see the crisscross appearance of the helter-skelter as they mentioned. And if he says hypertrophied myocytes, then can I have the answer again? Quick comments in the chat box. Yeah, myocardial dysarray. I mean, that's the word that we use in medicine. Myocardial dysarray. Pathology people use the word helter-skelter appearance. But yes, guys, I mean, no, this is not a ninja. Ninja would be for dilated cardiomyopathy. This is hypertrophied myopathy. Yeah, boxcar nuclei because of the fragmentation, right? Because of the fragmentation, those nuclei are crushed. Normally, the nucleus is going to be round. It's crushed because of the hypertrophied myocytes, and hypertrophied myocytes are a feature of dilated cardiomyopathy. The peculiarity in dilated cardiomyopathy is that the heart is dilated, but the muscles are hypertrophied. Only some, not all. Majority of ones are damaged. Majority are damaged, so the remaining myocytes will show a compensatory hypertrophy. So we can see a asymmetry with respect to the myocytes which are present. And then they have given this last image in which you can see a very characteristic jumbo size atria present. Yes, guys. Jumbo size atria would be present, right? Super dilated atria present in this case. Yes, guys. The last slide, please. Can I have the answer, please? What is the type? Okay, I can get a banana there. I am getting a lot of inputs. Guys, there is fibrosis in the muscle of this patient. Come on. You're not supposed to get this right. This patient is having a normal size left ventricle. If you compare with the cavity of the right ventricle, if you look at the cavity of the right and the cavity of the left, it looks equal, na? The cavity of the left and the right ventricle is equal. Size is equal, but atria are bigger than ventricle. Normally, like, it is the ventricles that are bigger than the atria, but in this case, it's the atria that are bigger than the ventricles. And what you are also seeing in this particular case is a lot of, I would say, pink amyloid material deposited between the myocytes. So this is like a slide for restrictive cardiomyopathy, and one of the important causes for this is going to be amyloidosis. That is why the pathologist will say pink amyloid material deposited. Pink amyloid material deposited. In fact, this is the rarest type of cardiomyopathy, and the most common cause for the rarest type of cardiomyopathy happens to be amyloidosis. The features are going to be standard with respect to congestive heart failure, and I'm also going to use this opportunity to mention regarding the ABCD of pulse. So I'll just write it on this particular slide. I mean, A is for anacrotic pulse. That would be a feature that would be seen with respect to valvular aortic stenosis. Then is alphabet B is for Bispherians pulse. The third one is collapsing. That is super easy. I mean, collapsing pulse, nobody makes a mistake. And then we get a twice beating pulse. When I say the word twice beating pulse, both in systole and diastole, that's called as a dicrotic pulse. Quick answers here. When it comes to anacrotic pulse, it's going to be valvular aortic stenosis. Bispherians is hypertrophic cardiomyopathy. Collapsing pulse is going to be valvular aortic regurgitation. And when it comes to dicrotic pulse, then dicrotic pulse would be seen with respect to dilated cardiomyopathy. Yes, Utkarsh, you're right. In patients like beta blockers and digoxin, well, digoxin, I'll say, is absolutely contraindicated in these patients because the heart functioning is severely compromised. Now, among all these cardiomyopathies, we'll also quickly revise regarding Takotsubo cardiomyopathy, and the mnemonic you can use to remember Takotsubo cardiomyopathy would be tuned, TUNED, and that is for Takotsubo means a jar to trap the octopus. So the left ventricle of this patient would be bulging out like this. This is mainly because of unexpected emotional trauma like death of a loved one. That is why we call this condition as broken heart syndrome as well. And there is a catecholamine surge that is happening in this patient. It is a catecholamine surge that would be responsible for Takotsubo cardiomyopathy. The diagnosis of this condition is usually made in the cath lab. The diagnosis of this condition will not be made in the routine emergency because ECG of this patient will be showing a ST segment elevation. The cardiac biomarkers in this condition will be super elevated. So we will think that this is a case of ST elevation MI, but when we send it to the cath lab, when they do a coronary angiography in this patient, the coronary angiography of this patient would be normal. So that's why I've written no obstruction of the coronary circulation. It's a differential diagnosis of ST segment elevation MI. Well, now cancel the PCI procedure, will not do a primary percutaneous coronary intervention in this patient. Rather, we will manage this patient conservatively. Quick comments in the chat box. How would you manage the cardiogenic shock of this patient? Yes, normal cath lab findings. Quick answers for Takotsubo Cardiomyopathy, which is like a representation for a jar that is used to drop the octopus. Yes, guys, as far as ST elevation is concerned, doctor, for this condition, it's not necessarily postmenopausal woman. It can be anybody, right? Takotsubo means intense emotional trauma contributing to damage to the heart. Okay, so yes, we will not be using dobutamine in this patient. Traditionally, we use like dobutamine, or we use dopamine, or we use norepinephrine. All of these are absolutely contraindicated for management of this condition. The cardiogenic shock in this condition will be treated by use of intra-aortic balloon pump, IABP. We do not use inotropic drugs because they'll increase the catecholamine levels now. Why? Catecholamine excess is the reason for the pathogenesis of this condition. It is the catecholamines that are causing damage to the heart. So if I'm gonna be like, using drugs that are gonna increase the catecholamine levels, that's gonna be counterproductive. So it's intra-aortic balloon pump, and yes, Impella is another device that we can be using. Very good answer. And then we'll be able to manage these patients effectively. And then subsequently, like we'll be able to, in majority of cases, recovery, if the diagnosis is made on time, then the recovery of this patient would be done. So we are sorted for like the type of cardiomyopathies. I mean, in this particular slide, I've tried to focus on various types of cardiomyopathies, including the one that is asked in medicine. And one that I've discussed on the previous slide is arrhythmogenic right ventricular dysplasia, which is a hot favorite of our examiners. Now, I put up a question before you, and this would help us solve the questions on murmurs as well. Graham-Steele murmur, they're the two classical ones that they love to ask. One is Austin Flint, the second one is Graham-Steele murmur. So yes, guys, quick comments in the chat box with respect to Graham-Steele murmur will be seen in which of the following conditions? Absolutely correct. Graham-Steele murmur is a feature of pulmonary artery hypertension. When there's a pulmonary artery hypertension, this can contribute to development of a mild pulmonic regurgitation, and this mild pulmonic regurgitation would then be contributing to development of a early diastolic murmur. So that's a Graham-Steele murmur. In contrast, I'll be asking you for Austin Flint also, but don't hit the comment box for Austin Flint at the moment. My next question to you guys is, what is the cutoff for pulmonary artery hypertension? Pressure more than how much on catheterization would be diagnostic of pulmonary artery hypertension, like the normal mean pressure in the pulmonary artery. Yes, I will discuss Austin Flint also, guys. Give me a second. My question to you guys is, and I would like everybody to hit the comment button simultaneously, pressure more than how much is pulmonary artery hypertension? Your answer would be given as more than 20 millimeters of mercury. Can you tell me what test is done to check for whether you should give calcium channel blockers to the patient, or should you be giving bosentan to the patient? What test would be done? Anything more than 20 millimeter of mercury. I'm talking about mean pressure being more than 20 for diagnosis of pulmonary artery hypertension. What test would be done for identification of the fact that should you give calcium channel blockers? Yes, we'll be giving inhaled nitric oxide. That inhaled nitric oxide would be called as a vasoreactivity test. What I imply by the word vasoreactivity test is that we'll be using this test to, we'll be making the patient use inhaled, I stands for, INO stands for inhaled nitric oxide. And on basis of this, we can then decide what is the treatment to be given. One can be calcium channel blockers. Second is gonna be bosentan or ambrisentan. If they don't say anything in the question, then your straightforward answer is ambrisentan is the drug of choice for pulmonary artery hypertension. Otherwise, like cool, you can mention that as first line drug to be introduced as calcium channel blockers in the patient as well. Yes, vasoreactivity test, inhaled nitric oxide. A related MCQ, I'll use a separate color to ask you this. In which condition would you be checking for exhaled nitric oxide? In which medical condition would you be choosing exhaled nitric oxide for your diagnostics? Yes, guys, waiting for your answers. One was inhaled nitric oxide. Second question is regarding exhaled nitric oxide. Yes, bronchial asthma, we call it fractional excretion of nitric oxide, is useful for diagnosis of asthma. So I had very good inputs here with respect to the two very simple tests. So just take care of that question when he says inhaled versus exhaled nitric oxide. Now, as far as Austin Flint murmur is concerned, again, we'll be talking about, the The type of murmur that would be seen in this case, Austin Flint murmur is always going to be seen in patients who are having severe variety of valvular aortic regurgitation. And once you have this severe aortic regurgitation, there's like a large volume of blood coming back in the heart. And when you have that large volume of blood coming back in the heart, it would result in development of a mid-diastolic murmur. Therefore, what you need to do is remember some hacks. So I'm going to tell you quick hacks to remember mid-diastolic versus early diastolic murmur. The mnemonic that we have discussed for mid-diastolic murmur goes by the name of CAM, where C would be standing for like Carey-Coombs murmur. I hope everybody remembers that. Then it's going to be Austin Flint murmur. And then is going to be mitral stenosis. That's anyway a hot favorite of our examiners. And the last one would be a flow murmur. So these are like simple mnemonics which can be used to make our life easier with respect to mid-diastolic and early diastolic murmurs. The mnemonic for the right hand side is GAP, where G would be standing for Graham Steel. That's the only one that he'll be asking you for the right hand side. Then is for aortic regurgitation of the mild variety. And then is going to be the pulmonic regurgitation of the mild variety. So pretty straightforward questions present here. Comments in the chat box again. Carey-Coombs murmur is seen in which medical condition? It's a characteristic murmur, right? It's a murmur related to valvulitis. It tells you about the damage to the mitral valve leaflet, and this would be seen with respect to rheumatic fever. For Austin Flint murmur, as we've discussed, it's a feature for severe variety of valvular aortic stenosis. Mitral stenosis, anyway, like we'll talk about this subsequently also. There has been a question on mitral stenosis last time on FMGE exam with respect to the intensity of the murmur and the duration of murmur. I'll describe those technical aspects of intensity and duration of murmur of mitral stenosis. And then flow murmur example can be like atrial septal defect, where like the blood will go from LA to RA and then from the RA to the right ventricle. And Graham-Steele murmur is mainly because of pulmonary artery hypertension, and this pulmonary artery hypertension would then result in mild pulmonic regurgitation. तो उसमें छोटा सा, क्योंकि माइल्ड पी आर है तो लेस ब्लड वुड बी कमिंग, छोट कम ब्लड आएगा तो आवाज भी कम आएगा. सो दैट्स व्हाई लाइक देयर इज अ अर्ली डायस्टोलिक मर्मर दैट वुड बी हैपनिंग, एंड इफ दे गिव यू अ diagrammatic representation the same, then for early diastolic murmur the line diagram would be something like this: S1, S2 and S1, and you'll be noticing that the intensity of the murmur will tend to progressively decrease. You can see a declining trend for early diastolic murmur, whereas mid diastolic would be like much more longer with respect to the CAM mnemonic that I have mentioned. So since you have got this, and rheumatic is again what they love to ask you, so let's do another question. This would be two questions that have been asked in I think the second one is the FMG exam, but let's handle the first one plus. Yes, Dr. Lithia, you're right, that would be a seagull murmur. Known case of heart disease with recurrent sore throats, presents with shortness of breath. On examination, there's a hyperdynamic precordium with a water hammer pulse. There is like pistol shot sounds over the femoral arteries. I mean, I know the comment box is just going crazy with that pistol shot sounds on femoral arteries. That's going to be valvular aortic regurgitation, and there's a pansystolic murmur in a patient. So there are two lesions given in this question. One is that of aortic regurgitation, and the second one is that gonna be of mitral regurgitation. So it should be option number A, rheumatic heart disease with aortic regurgitation and mitral regurgitation is what is occurring in this patient. The most common valve involved in mitral rheumatic heart disease is mitral valve. The second most common valve is aortic valve. So I mean, this is like the reality of India, that even today, after so many years of independence, we still have sore throats. We have patients suffering from rheumatic heart disease. So we call it the disease of poverty. It's a heart disease of poor people. Quick comments in the chat box with respect to rheumatic heart disease. Which valve is not involved? Rheumatic heart disease, valve which is usually not involved. There are only four heart valves now: mitral, tricuspid, aortic, pulmonic. So yes, guys, which valve is unlikely to be involved? Mitral is the most common one. Aortic is the second most common one. Which valve is unlikely to be involved? So usually that is not involved is the pulmonic valve, but you can still be having pulmonary artery hypertension because of long-standing mitral stenosis in this patient. So absolutely correct. Yes, I loved that. Tricuspid regurgitation to hota hai na, Doc sahab. Tricuspid valve is the one that is involved in, it is MAT na. माइट्रल वाल्व इन्वॉल्व होता है, आयोटिक वाल्व इन्वॉल्व होता है और ट्राइकस्पिड वाल्व, ये सीक्वेंस है ना एमएटी का. लेकिन पल्मोनिक वाल्व यूजुअली रोमैटिक हार्ट डिजीज में इन्वॉल्व नहीं होता है. सो कूल मैन. लेट्स डू द नेक्स्ट वन. अ पेशेंट हैज बीन डायग्नोज्ड विद mitral stenosis. What will decide the severity of mitral stenosis? And I'll just do a line diagram here. Meanwhile, I'll be waiting for you to hit the comment button. In mitral stenosis, what will happen is pressure in the left atria will be more, because a quick diagram here representing the same. The opening in this area, this case is narrow, right? This is going to be a narrowed opening. So there's going to be a higher pressure in the left atria of the patient, and due to higher pressure, there would be a loud opening snap. That's the first thing that's going to happen in this patient, loud opening snap. Then there's going to be a murmur that will peak in intensity, and then is going to have a secondary spike that's called as a pre-systolic accentuation, because after S1 there's gonna be systole happening. But if I'm gonna modify this diagram by making this obstruction even more narrower, it will cause an increase of pressure. If the pressure will increase further, the valve will open much more earlier as compared to normal, and therefore what you can see in the line diagram is that the total length of the murmur is increasing. I mean, just check it out, man. If you look at this diagrammatic representation, the length of the murmur previously versus the length of the murmur now, the length of the murmur has increased, and therefore what you can also see in this line diagram is that the gap between the S2 and the opening snap has progressively become reduced. So I had very good inputs from this one. This is very classical teaching that is given in Hutchinson clinical methods, and the same question has been asked multiple times. So what you get in this condition is increase in the length of the murmur and a reduction in the S2 and the opening snap gap. It is the reduction in the S2 and the opening snap gap that would be seen in this case. That's because of the length of the murmur that would be increasing. So cool, guys. I think this was a very good input from you guys with respect to mitral stenosis. We will have to treat these patients with percutaneous mitral balloon valvotomy. That would be an indication for severe variety of mitral stenosis. I mean, every time we have severe mitral stenosis, we go in for a percutaneous mitral balloon valvotomy. But if it becomes calcified severe mitral stenosis, then we will not be. In fact, I can just add a quick slide to this. Yeah, I think you have to watch LRR for this. Like if you are even an FMG student, man, this is a question from the last time's FMG exam only. I mean, it's a screening exam, but they're asking you how to evaluate the severity of mitral stenosis. Okay, so quick inputs here. The quick inputs for you guys are like this. Like, you know, if a person is having a severe percutaneous mitral balloon, severe mitral stenosis, and it becomes calcified also. Wait for my question, guys. Wait for my visual cue. Severe calcified mitral stenosis, we do not do a percutaneous mitral balloon valvotomy because the balloon is gonna cause the valve to break into pieces, and those fragments will then go into the brain of the patient. We can have like embolic stroke kind of a presentation. So in this patient, what we will do is deploy an artificial heart valve, that is a prosthetic heart valve. And when we plan for a prosthetic heart valve, there can be two possibilities. One, you can talk about metallic, and instead of metallic, we can also talk about biological prosthetic valve. What I mean by biological prosthetic valve is that it can be from a pig's heart. So I can use the word porcine. It can be coming from a cow's heart. So I can use the word bovine, or it can be coming from a cadaver also. Question for you guys is, if a cadaveric heart valve is being used in a patient, what is the technical term for it? One-liner question. If it's gonna be a cadaveric heart valve that is used, like I've said porcine, I've said bovine, then I've said cadaver. So if it is a cadaveric heart valve that is being used, what's the technical term used for it? Okay, yep. If it is, yeah, the superior two are obviously gonna be xenografting, that is okay. But he said, what is if the cadaveric heart valve, then we are gonna be using the word, no, it will not be called as a allograft, guys. I think some doctors immediately came up with the correct answer. Yes, I think Dr. Fatima was the first one to come up with it. That was homograft. It would not be called as allograft. Allograft is where it's like a cousin, brother or sister, na? When it is first degree relative. So this is the question that was asked, that if it is the biological heart valve that is going to be used, then like a biological heart valve means cadaveric, then it is a homograft that would be used. Otherwise, we'll anyway be using a metallic heart valve. Metallic heart valve will need lifelong anticoagulation. So there will always be a need for OAC, that is oral anticoagulation. And usually the drug that would be required in this patient would be warfarin. And if he says what will be the target INR that needs to be achieved, then the target INR that we need to achieve in this patient would be any value between something in the range of 2 to 3. So there are two questions I just wanted to bring to your attention. One is the homograft question. Second is the target INR that I need to do in case a metallic heart valve is used for cases of mitral stenosis. So we are sorted for this question, and MS happens to be an important topic that is usually asked, and therefore I spoke about it. And let's not talk about must know facts about JVP. So bit of the theory component is what I'm discussing after these questions. And the first one is with respect to Kussmaul sign. Kussmaul sign, you know, this is always going to be like a rise of the JVP. JVP. Because this is a revision session, we'll do some theory component also. Must know facts with respect to JVP. को small sign basically means a paradoxical rise, because normally you would always be having is a fall of JVP, but in this case it is reverse that is happening. It's the paradoxical rise of the JVP that is happening. The mnemonic for this is gonna be like COPS, right? So the COPS would mean that C would be standing for constrictive pericarditis. Constrictive pericarditis, COPS CP, constrictive pericarditis means that there is gonna be a calcification present in the valve. Then alphabet R will be for restrictive cardiomyopathy. R is RCM, restrictive cardiomyopathy, and then subsequently the next input would be for a right ventricular failure. So these are like three conditions where we'll be having small sign. RCM is a very good answer there. So you can use CRR, or you can see these are like three situations where you would get a small sign, and the MCQ will always say not seen in with respect to cardiac tamponade. Very good. Right ventricular failure, अब वो कैसे लिखेगा वो उसके ऊपर है, right? He can be writing right ventricular failure by writing the word inferior wall myocardial infarction. He can be writing it as cor pulmonale. He can write the word acute cor pulmonale. So it doesn't matter. I mean, anytime there's a right ventricle failure, inferior wall MI, cor pulmonale are usually the situations where, because of the right ventricle compliance being lesser, the JVP will be showing a rise instead of a fall, because heart cannot accommodate the blood. Your and my heart does not have a failure, so our heart can accommodate the blood. Okay, cool. Large A waves would be seen in is again a question that has been asked repeatedly. This would be due to obstructive lesions on the right side of the heart. So you can keep the comments going, guys. Medical conditions that contribute to large A waves in a patient would be tricuspid stenosis. Very good. Okay, so I'm having good answers there also. Then is pulmonic stenosis. These are like standard situations where we'll be getting is large A wave. Somebody commented mitral stenosis also, but then mitral stenosis, Dr. Tosif, I would like to clarify, is only long standing. So if you get a question where tricuspid stenosis is also given and mitral stenosis is also given, don't select mitral stenosis. It is long standing mitral stenosis. Plain mitral stenosis given, this has occurred in the exam. He gave TS also and MS also in the option, and he said select the one where you have a large AV present. So he'll not answer it as mitral stenosis, because mitral stenosis only long standing will cause it. So just a word of caution here. I mean, my job is to just keep on telling you what is the right thing, and then yeah, subsequently like even pulmonary artery hypertension would contribute to it. So causes the pulmonary artery hypertension, like you can write down a connective tissue disorder like scleroderma. Comment in the chat box for what antibody is used for diagnosis of scleroderma, guys. Then there are drugs which have been banned. These are like weight losing drugs like fenfluramines. They've been banned for weight loss. Yes. Okay, so scleroderma is like I think anti-centromere antibody that would be helping up in diagnosis of this condition. Yeah, one is centromere and the second is gonna be topoisomerase antibody. Between the two, the single best answer would be topoisomerase antibody, also called as anti-SCL70. So these are inputs for like, yeah, I had both inputs coming in, centromere as well as topoisomerase. The correct answer is anti-SCL यार दिया नहीं होता ना MCQ में, because SCL is going to be super easy, so most people are able to crack the question. So most of the time they'll be asking you regarding topoisomerase antibody for scleroderma, because there's a variant of this, no, CRESS syndrome. That CRESS syndrome is the one where you would be having centromere antibody. C for CRESS, C for centromere antibody, and the answer would be given as topoisomerase antibody. Yes, Dr. Rudrapal is the correct one here. Okay, cool. So don't answer centromere, guys. I repeat that again. That's only for CRESS syndrome, and CRESS syndrome may not have pulmonary artery hypertension, but diffuse involvement in scleroderma is the one which has pulmonary artery hypertension, which can contribute to death. Then he'll talk about absent A waves. Keep the comments coming. Absent A waves would be seen if the heart is twitching. If the heart is twitching, the answer for that is going to be atrial fibrillation. That's going to be one of the commonest arrhythmias in clinical practice. You see A wave is because of power, and if the power is lost, then the bad news is that you get absence of the A waves. Then is going to be Canon A waves. Canon A waves would be seen with respect to AV dissociation. What I mean by AV dissociation is that the atria and ventricles are contracting simultaneously. Imagine atria and ventricles contracting together, so the power of the two will be added, and that's going to cause like super large A waves. I put a video on this on the PrepLadder channel also. You can check that out. We call it frog sign. Frog sign means big time pulsations in the neck in this patient is occurring. So AV dissociation is what is going to be seen with tachyarrhythmias and bradyarrhythmias. So if he says which bradyarrhythmia would be causing it, then a lot of people have made the correct answers there. That would be complete heart block. The other name for that would be third degree heart block. So the theory part to be remembered is complete heart block, third degree heart block, Stokes-Adams syndrome. Other to difficulty pata kya hai? That in medicine they use the different names for the same condition, and that causes error of judgment. So the Brady condition is one and the same thing. It is complete heart block, third degree heart block, or Stokes-Adams syndrome. And if it says tachy, then yes, a lot of comments were coming in for the tachy component. That's gonna be like uh, ventricular tachycardia, junctional tachycardia, and can be seen even in PSVT also. But then primary answers would be like VT and JT, that is ventricular tachycardia and junctional tachycardia. Then we'll talk about absent X descent. And for absent X descent, you can see a valvular lesion here. You can see blood leaking like this to the top across the tricuspid valve. And connected to the right side of the heart would be ultimately the jugular vein. And the jugular vein column should be falling downwards. So you can see two vectors, one is going down, the other one is going up. And both of these vectors, if they are of equal strength, they can cancel each other. You can see one is going down, other is going up, so they'll cancel each other. So therefore, absent X descent, because X is going to be related to atrial relaxation, there are two vectors which are fighting with each other, and therefore this is a very common question that is again asked. Absent X descent would be seen with respect to, the answer would be given as tricuspid regurgitation. So again, very good answers, and I would just like to extend your knowledge base here by just drawing a line diagram representing it. I mean, this is how the normal JVP waves would be coming. It would be AAC, this would be AACV, then is the X and the Y descent. And what's going to happen in my particular case is that there will be like this C happening, then there is no X. There is no X happening in this person, and rather directly from here, the whole system will lift up in a tricuspid regurgitation of the more severe variety. And therefore, I have created one more MCQ for you that would be called as CV wave, or maybe written in the MCQ as a giant V wave. And second, what you can also notice in this line diagram is where I put the star mark there, it's like suddenly coming down. Like it looks like a roller coaster ride, right? If you go to any roller coaster ride, it just takes you up and then suddenly you plummet downwards. So where the star mark is put, that is what is called as a steep Y descent. So ultimately, tricuspid regurgitation is answer for three questions. Yes, Lancisi sign is a very good answer. Apply on tricuspid regurgitation is answer to three MCQs. It's gonna be absent X. If you can mentally visualize this diagram now, X is gonna be absent, then after C what will come? V wave, and then there's gonna be a very very prominent Y descent happening. So you need to remember this information. That's gonna be absent X, CV wave, and then a steep Y descent. That's gonna be a feature with respect to tricuspid regurgitation. So one, they ask you about tricuspid stenosis. Second, they ask you about tricuspid regurgitation with respect to the findings in the JVP. And now we come to the hot favorite of our question. Very good, Yashti. You came up with a correct one. Absent Y descent. Absent Y descent would be when the ventricular filling will not happen, and you can see it could be blood, it could be fluid outside the heart of this patient, and if there's blood or fluid outside the heart, it will crush the heart, so filling is not going to happen. There's going to be obstructive shock happening. So absent Y descent is like a question which I think even if you are sleepy, even if you are deep asleep and somebody wakes you up and says, when do you get an absent Y descent, you say, okay, don't bother me, it is cardiac tamponade, and we go back to sleep again. Two standard questions that I'm going to write here is steep X, steep Y, and then it's going to say the word steep X and absent Y. It is just technical jargon by the examiner. Don't cut the noise, right? That's the slogan that we say. So steep X is just a distraction. It's a distraction. You just need to focus on the word absent Y, and absent Y is CT, that is cardiac tamponade. But if you get a combination of the two, that would be constrictive pericarditis. So two very straightforward data that I've currently mentioned before you. And now is a question that is coming up. If a person is having hemopericardium, like this guy got a stab injury to the chest. Because of this penetrating injury to the chest, there is a hemopericardium. Then the person will develop obstructive shock. He will develop Pulsus Paradoxus. The pulse will tend to disappear in the phase of inspiration. How would you manage this patient? Options are, you have to answer it as either thoracotomy, or you have to answer it as pericardiocentesis. A quick answer that I'm waiting for you guys. If you are saying thoracocentesis, you can just type the word T. Thoracotomy. Okay, I give three options: thoracocentesis, thoracotomy, and then pericardiocentesis. Yes. Okay. So I'm getting a lot of inputs there with respect to pericardiocentesis versus thoracotomy, and then I made one other option as thoracocentesis. I think I've highlighted this earlier, guys. If it is gonna be blood due to a stab injury, then even if you do a pericardiocentesis और blood आ जाएगा ना वहाँ पे, because there could be a laceration of the cardiac muscle, because there could be a hole in the heart, there could be laceration in the muscle. So even if you remove that blood, more blood will come. So it's not going to serve the purpose. So don't answer it as emergency pericardiocentesis in this patient. Do not answer echocardiographic guided pericardiocentesis. Your answer would be given as thoracotomy. We need to fix the bleeding. We need to fix the damage to the heart. So the technical word that we'll be answering is emergency resuscitative thoracotomy. I've emphasized this point multiple times earlier. We are doing a quick revision today that for suppose I was saying to you, lung cancer patient is having lung cancer patient is having tamponade, or if a tubercular pericarditis patient is having cardiac tamponade, what will you do? Then it is understandable that we can be doing pericardiocentesis in a patient. So for medicine causes, but if he says medicine causes, like one of the cancer that can metastasize to the heart is oat cell cancer. So if he gives you a scenario of a malignant pericardial effusion, or if it is tuberculosis, so he says infective etiology responsible for those hardcore general medicine causes where there is going to be tubercular pericarditis followed by pericardial effusion followed by development of cardiac tamponade, because ज़्यादा fluid बढ़ जाएगा ना, more fluid will accumulate around the heart. So if it's going to be oat cell cancer and tubercular pericarditis, in those circumstances, guys, what you are going to do is pericardiocentesis. That would be done echocardiographic guided. And from where would you insert the needle? Yes, guys, comments in the chat box. Where would you insert the needle in pericardiocentesis? Options are second intercostal space, fifth intercostal space, seventh intercostal space, ZP sternum. Yes, guys. We are doing an echocardiographic pericardiocentesis. In a case of tubercular pericarditis who went into tamponade, needle would be put in through second space, fifth space, seventh space, or would you be using a Zephyr approach? Okay, fine. I think everybody got it right. Zephyr approach, guys. Don't answer fifth space. That is for that tension pneumothorax management that we'll be discussing in the later part of the day in the session too. So it is always a Zephyr approach. Now, I mean, if I want to approach the heart, I don't want to go by the lungs. If I want to approach the heart, I don't want to go through the lungs, as simple as that. So that's why it is Zephyr approach that would be done. It is sub-xiphoid and we'll aim for the left shoulder of the patient. It would be guided procedure. Then we'll put in a pigtail catheter, and through that pigtail catheter, because if I put in a needle, it can touch the heart, it can damage the heart also. So we'll just go poke the pericardium, then we put a pigtail catheter, and through that we can remove the pericardial fluid, send it to laboratory estimation. We can do CB NAT also, so that we can identify the etiology per se. So that is when we are sorted with respect to the causes that could be asked. And let's talk about another question at the moment. Okay, constrictive pericarditis finding, doc, it's coming up. That JVP finding of constrictive pericarditis is coming up once again, the steep X and the steep Y. But since you asked it, okay, I'll just pause for a while these guys are figuring out the answer to this question. Is that in constrictive pericarditis, doctor, what happens is because there's a calcification outside the heart, imagine it to be like a eggshell. So because there's like a thick zone of calcification out of the heart, the filling of the heart in the late part of the diastole is compromised. So the heart will compensate by increasing the filling in the early phase. So what you get in patients of cardiac tamponade, constrictive pericarditis, is that the early diastolic filling is exaggerated to compensate for the decreased filling in the later part of the diastole, because later there is a calcification outside the heart. So that rapid ventricular filling that is exaggerated, is responsible for the finding of a steep Y descent in this patient. I'll do more justice for this as we move on in the discussion, but at the moment, since the question came up, I thought I should just speak about it. That was like an impromptu answer that I cannot stop myself from saying, considering that these are genuine queries and very academically oriented queries. Okay. What is the most specific ECG finding that is seen in patients of pericarditis? Then ST segment, guys, is seen. ST segment changes are seen in so many conditions. Na? ST segment changes are found in so many conditions. Therefore, it is not an ST elevation with concavity that is to be answered. Like this is what happens in this condition. I'll just draw it before you so that we can discuss it subsequently. What you are seeing is a slight twist with respect to the baseline. What you're noticing is a slight twist with respect to the baseline. What you're seeing is, okay, let me just zoom it in. You can see a normal ECG that I've drawn, and then subsequently you can see this ST elevation with concavity that is happening. But along with this, you are also noticing this characteristic finding that I'm showing, that is the PR segment of the patient is going down. right? So the most specific ECG finding that you get in pericarditis, specific one is sensitive. Sensitive is obviously correct. If I say what is the sensitive ECG finding for pericarditis, acute pericarditis, then never an issue. Then answer will be option number A. But specificity is something that is like, seen exclusively for this condition. That would be like a PR segment depression. So the answer in this particular question would be given as option number C. That is gonna be like a PR segment depression. Guys, that party sign and all those things are for myocardial infarction. No, it is concavity. I agree to whatever you guys are saying. You see, option number A, boys and girls, listen to this carefully. Acute pericarditis is inflammation of the ventricles and the atria. We get an ST segment elevation with the concavity, and we simultaneously get is the PR segment depression that I've highlighted in this particular sketch. So yes, one of the early findings that we see in pericarditis is ST segment elevation with concavity. But if he changes the question to that of specificity, then it is going to be answered as PR segment depression. Party sign we'll talk about in the subsequent part of the ECG. So acute pericarditis, the most common cause for this is anyway idiopathic. But one of the ECG findings, a very characteristic one that is asked for this would be, though with COVID also, no, we were having pericarditis, people were having chest pain, but then the differentiation can be made. And usually like in pericarditis, the chest pain will radiate to the left shoulder. The nerve that carries the pain to the left shoulder is usually the phrenic nerve. Okay, so I think we are right with respect to, no, not B, but it would be C. Yeah, we can have viral Coxsackie B, Coxsackie parvoviruses. Those are other viruses which can contribute to development of pericarditis. Yes, viral can be there. Exactly. COVID, Coxsackie, parvovirus. Those are like the viruses which are responsible. The answer to this question is option number C, doctor. It's a PR segment depression for the most specific finding with respect to acute pericarditis. It's C as an answer for the specific finding, and like the common finding that we get is anyway the ST segment elevation with the concavity. The correct answer, I'll remove the tick mark from here so that there is no confusion. The sensitive part is obviously the first one, with the specific part is a PR segment depression. No, in this case, sore throat may or may not be present, so we can't predict it. Then next up is pericardial effusion. There can be two reasons behind it. The common ones in India is either going to be TB, or if it's not going to be TB, then it's going to be, yes, Shubham Gehlot, you made it very correctly. The chest pain going to the back, doc, that is for aortic dissection, na? If it's chest pain going to the back, then it's gonna be aortic dissection. Every time you read, since you put that up, I just wanna highlight, every time you read a question of a hypertensive patient, and the question says that the chest pain is showing radiation to the back, especially if he talks about radiation to the interscapular area. Whatever else he may say subsequently does not matter. This is more than sufficient to crack the question of the tear in the aorta. That is gonna be aortic dissection. So in this case, like what I was describing was the pain radiating to the left shoulder, but it is aortic dissection that would be answered for pain in the interscapular area. And as far as the investigation choice for aortic dissection is concerned, since I've spoken about it, let me just complete it here only. For the investigation choice for aortic dissection, the answer will depend upon the blood pressure values. Like if the blood pressure is crashing and it is very, very low, then I would like to do a bedside echocardiography, or we can do a transesophageal echocardiography. But if the BP of the patient is normal to low, but is at least not on a crashing state, then we can do is a CT angiography. CT can be done again very fast. And in a CT angiography, what we can check out is the tennis ball appearance. And then is subsequently like type A and type B aortic dissection. Type A will always need surgery. Type B, we can go for medical treatment with labetalol, and subsequently a surgery in the patient can be planned. So I think since the question mentioned about, somebody asked about radiation in the back, so I thought it imperative to mention about it. And coming back to the agenda that we are having at the moment, like tubercular pericarditis, there's going to be TB, then there's going to be malignancy. It can be breast cancer, it can be malignant melanoma that can be used. Esmolol, doctor, like, yeah, we can be using esmolol, but then because of the extreme vasoconstriction, that alpha part also has to be neutralized. So between esmolol and labetalol, I think a better answer would be given as labetalol for because hypertension is the trigger, na? And there's extreme amount of vasoconstriction happening. So alpha will not be neutralized by giving esmolol. So you're right, like esmolol can be used if the BP is dramatically low, but then overall to treat the hypertension state of this patient, it would be labetalol as a better answer. Okay, as far as pericardial effusion is concerned, there would be two ECG findings which are very, very characteristic. One is low voltage ECG. Can I have the diagnostic criteria low voltage ECG? Quick comments in the chat box, guys. What is the definition of low voltage ECG? Your answer would be that the height of the R wave and the depth of the S wave would be less than 5 millimeter is the definition of low voltage ECG. That would be one of the characteristic features that would be seen low voltage ECG. Another finding. Okay, sure. Offline be. Okay, and then is gonna be another ECG finding that will come because the heart is dancing in a bag of fluid. You see, it's a dynamic motion, to and fro movement of the heart. Heart is dancing in a bag of fluid, sloshing like waves in a sea, ना समुद्र में ऐसे waves आती हैं. So because of the waves created, the voltage recorded by the electrodes will keep on fluctuating, and therefore this finding would be referred to as electrical alternance. Electrical alternance is like a very characteristic finding that's again seen with respect to pericardial effusion. And when it comes to the X-ray findings in this patient, the cardiothoracic ratio will be increased. Somebody mentioned very rightly water bottle heart. And if somebody is money minded, then he will not say water bottle. If you are like survivor with respect to sports, then you say water is the most precious thing. If somebody is like not exercising and somebody is money minded, then बोलेगा कि भाई ये तो money bag है. So water bottle and money bag appearance are like two very characteristic words. At this junction, I just want to emphasize to everybody who's participating in this discussion, guys, every question you solve is gonna take you closer to the final victory. And every hour's productivity will keep on changing because I continuously keep on getting these queries like कि focus नहीं बन रहा, attention span decrease होता है, तो आपने persist करना है. That is all that is required. Just sit there, right? Don't go out कि चाय पीने चल रहे हैं, चलो कॉफी पीने जा रहे हैं, गौतम नगर में बैठे हैं तो चलो भाई we go out and chill. No man, nothing doing, because if you go out you're gonna watch Instagram, it's gonna take out your energy, it's gonna decrease your attention span. So just persist. That's my message at the moment. You will be able to remember things, guys. It comes gradually. Normal cardiothoracic ratio will be 0.5. Heart occupies 50% of the space in the chest in you and me. Heart occupies 60% of the chest with respect to children. The normal values of cardiothoracic ratio with respect to adult and child are 0.5 and 0.6. In this condition, because there's going to be water outside the heart, in this condition, because as you can see there is like water outside the heart, therefore the appearance is looking very peculiar. That's why we call it a money bag or a water bottle heart at the moment. And like for this particular condition, we have to be proactive and do the investigational choice. If he says investigational choices, then the answer is none of them. The answer is echocardiography. Echocardiography can help you identify pericardial effusion from a low pressure cardiac tamponade to a cardiac tamponade, because ultimately the complication of this pericardial effusion would be specifically development of cardiac tamponade, where usually they'll ask you regarding the following aspects. As far as INI-CET is concerned, guys, this is it came up in the chat. My only thing is that it's like scuba diving. They just go more deeper into it. Like I mentioned a technical term, right? That has been asked in INI-CET exam. That is called as low pressure cardiac tamponade. I mean, when I write this or when I speak about it, the query of most people is, boss, cardiac tamponade is characterized by high pressure on the heart. Every time you say like this, now how come there is low pressure? So here it is only atrial collapse. If it's gonna be low pressure cardiac tamponade, guys, then only atrial collapse will be occurring. If only atrial collapse will occur, there would only be a 30% decrease in the filling. If there's a 30% decrease in the filling, the BP will decrease by only 30%. So in this condition, you will not be having an unrecordable blood pressure. You will only have hypotension. So therefore, because you will have hypotension and not an unrecordable BP, Pulsus Paradoxus will not be seen in patients who are having low pressure cardiac tamponade. I'm starting this topic of cardiac tamponade by saying a very peculiar thing, that if he says the word low pressure cardiac tamponade, then we don't have Pulsus Paradoxus, because traditional data for the topic of cardiac tamponade is presence of Pulsus Paradoxus. Low pressure cardiac tamponade simply means that there is gonna be there's only atrial collapse happening. And subsequently, if I say the word cardiac tamponade, that means it's high pressure, and that's when the Pulsus Paradoxus finding would be coming. Quick comments in the chat box. In Pulsus Paradoxus, the inspiratory fall in systolic blood pressure should be more than how much? I'm writing SBP I means inspiratory fall. of systolic blood pressure. When do we say pulsus paradoxus? For checking pulsus paradoxus, it is normal breathing that is recommended. This was again a question that was asked in INI-CET exam, that when you are checking for pulsus paradoxus, what will you ask the patient? Deep inspiration, deep expiration, mid inspiration, or simple normal breathing? We will not ask the patient to do a deep breathing, because if he will do a deep breathing, the inspiratory blood pressure will fall substantially and it can even cause syncope in a person. So it is like normal breathing that would be required. Normal fall is like at least 10 millimeter, and in this patient you will say more than 10 millimeter. That's a good answer, just to discriminate, and they've added 2 points extra. So a better answer will be to say it a little more than normal. In you and me, the inspiratory blood pressure falls by less than 10 millimeters, and in this patient it would be like more than 10. So the more specific answer will be 12 millimeters, and it is normal breathing that is required. In cardiac tamponade, the person's BP will become unrecordable, so he will use the technical word, that is obstructive shock, and then he will ask you regarding the JVP findings. Please comment in the chat box. So small sign will be seen or will not be seen. You have to say seen, not seen. Please comment in the chat box. So small sign, waiting for your answers. Yes, we'll be having is a steep X, and we'll be having an absent Y. You have to tell me whose small sign will be seen or will not be seen. Absolutely, it will not be seen because there is absent Y, na? Absent Y means that there is like no feeling occurring in the heart of this patient. So as such, a small sign is a feature that is seen in patients who are having constrictive pericarditis. It is seen in restrictive cardiomyopathy. It is seen in right ventricle failure, but it is not seen in cardiac tamponade. I had very good inputs here from a lot of young guns, and therefore, how will he write this? He will write like this in the MCQ: elevated JVP with this. He will write the word non-pulsatile elevated JVP. Guys, in your entire career in cardiology, in your entire medical domain, only time you read the word non-pulsatile elevated JVP is for cardiac tamponade. Non-pulsatile elevated JVP. Now, for those of you who have listened to me, I would like one more comment here. Tell me one more medical condition where lung cancer will be a cause and there is a non-pulsatile elevated JVP. A miscellaneous question here. Non-pulsatile elevated JVP is seen in cardiac tamponade, is not in options. Non-pulsatile elevated JVP is given in the question, but there is like, no mention with respect to any cardiac tamponade. Absolutely right. The answer would be given as superior vena cava thrombosis, and this superior vena cava thrombosis can be occurring with respect to lung cancer, central lung cancers like small cell cancer, squamous cell cancer, can cause a mass effect. They can press on the superior vena cava, they can cause a superior vena cava syndrome. Yes, guys, the next answer would be tension pneumothorax also, but not plain pneumothorax, right? It is tension pneumothorax where a same kind of a situation can be seen in a patient. Absolutely right. Very good. Another question coming up. Since I had very good answers, so I can't stop myself from asking you guys, what is the most common cause of tension pneumothorax? Though respiratory system is scheduled for the second session for today, but yes, we are gonna put up a question. What is the most common cause of tension pneumothorax? Pankos tumor will cause neurological manifestations like wasting of the intrinsic muscles of the hand, and then Pankos tumor can contribute to pain, radicular pain occurring in the arm, Horner syndrome manifestations. This is a central lung cancer, which would be a better answer, superior vena cava thrombosis. Okay, trauma. So I just want to add to the word, don't answer it as plain trauma. That will be given in the options. Your answer will be given as barotrauma. The most common cause of tension pneumothorax is not penetrating trauma. I want to emphasize this, guys. The most common cause of tension pneumothorax is not trauma. It is barotrauma. It is ventilator. No, it's not blunt trauma, man. That's what I'm saying. In the options, blunt trauma will also be given. In the options, penetrating trauma will also be given. All three will be given. Penetrating भी लिखा होगा, blunt trauma will also be given, barotrauma will also be given. But if it says what is the most common cause of tension pneumothorax, it is ventilator patient dysenergy. There is an asynchrony between the ventilator effort and the patient's effort, maybe because adequate sedation was not happening. So the leading cause for development of tension pneumothorax is barotrauma, guys. You have to remember this information. I had to say this because I could not wait for the second session to come up here. Two must know informations for this time. At this time is if he says cardiac tamponade with hemopericardium, if it's penetrating trauma to the chest, stab injury to the chest, that there's no rule of pericardiocentesis, it's a thoracotomy. And if it says tension pneumothorax, the number one cause is going to be mechanical ventilation. No, barotrauma, no, Dr. Gaurav, not barotrauma is not like a blast, bomb blast or like a underwater explosion. No. I'm talking about ventilator patient asynchronous. जैसे COVID में हो रहा था ना. You see, we were putting patients of COVID on ventilator, and then because the lung pressures were not being, because there were limited number of doctors and there were so many patients. So when you have to ventilate so many patients, there can be errors, right? And every patient's lung compliance is going to be different. So if the settings are not appropriate, and the peak inspiratory pressure is higher, then it can contribute to development of this lung to burst, and that is like tension pneumothorax. So yes. Spontaneous may vitals will not be affected, but it is tension pneumothorax that the vitals will be affected. The next point to be remembered is that ECG showing a low voltage ECG, low voltage ECG or electrical alternance is a common thing that is seen. I'm writing it with a separate color because this is a common thing between pericardial effusion as well as patient who are developing cardiac tamponade. So don't base your answer on the basis of cardiac tamponade. Don't base your answer of pericardial effusion and cardiac tamponade on the basis of low voltage ECG. Check out the data in blue, that would be useful. And the chest X-ray of this patient will also be showing a money bag appearance. The only difference is that the money bag will be like, much more bigger in size. Don't use ECG and chest X-ray as a discriminating factor. If ever in doubt in the MCQ with respect to pericardial effusion and tamponade, straight away check the blood pressure values. Blood pressure values will never ever crash in pericardial effusion, but blood pressure values will always be crashing. Blood pressure values will always be crashing with respect to cardiac tamponade. This is like an important topic, so I spoke about it, and now we speak about constrictive pericarditis. In constrictive pericarditis also, because there is less blood coming in the heart, less will be going out. So there can be an inspiratory fall of systolic blood pressure more than 12 millimeters of mercury. So Pulsus Paradoxus can be seen in this condition. JVP in this patient, however, will be showing a very characteristic finding of Kussmaul sign. So that presence of Kussmaul sign will do the trick for the question, because Pulsus Paradoxus is gonna be a common thing between both tamponade MCQ as well as constrictive pericarditis. Even in this condition, there would be a low voltage ECG. Yes, I'll come to pericardial shudder in a while. That is, low voltage ECG is a common thing once again. Cardiac catheterization in this case will be showing that square root wave sign. Now, most of the time, you are going to be in a position to answer the question of constrictive pericarditis on the basis of the information that I mentioned. But otherwise, suppose, this is not working out, then what are the tricks that would help you solve this question are two things. First is, he may write the word pericardial shudder. Like what happened in last time's NEET PG 2024 in August was that he did not use the word pericardial shudder, he just used the word loud diastolic sound. So whether if he is comfortable, if he writes the word pericardial shudder, he writes the word pericardial shock, cool, man. I mean, I am sorted. But if pericardial shudder and shock is not given, then it would be a loud diastolic sound that would be given in this patient. And along with this, for constrictive pericarditis, what we would also get up in this patient would be what somebody mentioned for the JVP, that is a steep X, and then would be a steep Y descent for this case. Whereas in cardiac tamponade, it was an absent Y descent. So these are the discriminating features that would be present. Otherwise, pericardial shudder, pericardial shock would do the trick for you. Another finding in the X-ray of this patient would be presence of calcification. So cardiothoracic ratio will be increased in pericardial effusion. It will be increased in tamponade, but will be normal because now there is no fluid now. And most of the time, history of taking ATT would be given. If he himself mentions the fact that ATT has been taken by the patient for like 6 months to 1 year, now in the revised guidelines of National Tuberculosis Elimination Program, for extrapulmonary TB, the ATT is to be given for 1 year in contrast to the previous time. So if he himself mentions patient has taken ATT for 1 year and now is coming with complaints of pedal edema. Why pedal edema? Because there is going to be compliance of the right side of the heart being lesser, so there would be swelling in the feet. There would be subsequently left ventricle compliance being lesser, so there can be breathing difficulty. So patient has already taken ATT for 1 year. There is a pedal edema, there's a breathing trouble, and then is going to be the findings which are given in this case. Then these are the findings that would be given in a patient, including the findings of steep X and steep Y descent. The reason for that steep Y descent is that in this condition, and this somebody asked earlier also, so I'll just put it here. The reason for this patients having a steep Y descent is a exaggerated rapid ventricular filling, because the late phase of ventricular filling will be compromised because of the calcification of the heart. Imagine this patient's heart like a eggshell, and this is the only question in the exam where they'll give you a CT chest. In fact, in cardiology, CT chest will be given only 2 times. Let me just write it down. in a cardiology MCQ, if they're giving you a CT chest, either it's going to be a question of aortic dissection, where you'll be able to see that classical tennis ball sign. And in case like you are not having you're not having aortic dissection in the options, then another scenario where like a CT chest is given for the topic of interest, that is constrictive pericarditis. Because यार normally तो देखो ना, we don't do a CT chest for a person having a cardiac issue. We'll be doing a cardiac MRI then, right? If I have the facility, then it is a cardiac MRI that would be doing. So in this particular case, it's like aortic dissection and constrictive pericarditis, where CT chest would always be given in a question. Like you can see superiorly a lot of calcification outside the heart of this patient. You can see like this is a sequelae. What I'm trying to say is constrictive pericarditis is going to be sequelae related to constrictive pericarditis. And as far as the treatment of this condition is concerned, what we're going to be doing is a pericardial stripping procedure. What we do in this case is pericardial stripping that would help in managing our patients effectively. Absolutely right. Absolutely right. So, no, doctor, not the most common cause of constrictive pericarditis is not idiopathic. It is tubercular. It is acute pericarditis, which is idiopathic in origin, and it is constrictive pericarditis, which is a sequelae for tubercular pericarditis, where there would be a thick zone of calcification outside the heart of this patient. And the reason for steep, why I explain once again, is exaggerated. Because heart is trying to compensate for the late part of the filling being defected. तो कहता भाई जल्दी जल्दी भर लो. भाई अगर आपको प्यास लगा, right, if you're thirsty, right, and you know you won't get water earlier, so you'll try to drink whatever you are having earlier. Similarly, heart is, because he knows later नहीं मिलेगा, so it's trying to grab all the information earlier, or getting all the blood inside much more earlier. That's the exaggerated rapid ventricular filling that I have currently explained to you. So cool, guys. We are like sorted for the disease of the pericardium, and now we are having a question for you guys. You are an intern in an intensive care unit. Patient is having PVT. So comment in the chat box for the full form of PVT. And he says it's an open surgery, doc. It is CTVS, right? It's not like a routine procedure. That's why CTVS is a branch where like we say those cardiac surgeons are god. No, nowadays people don't take CTVS branch because they think that it is low paying job. I understand like salaries of doctors are lesser, but then CTVS is like god only, no? Okay. Yes, the full form of this would be a this would be a pulseless ventricular tachycardia. Absolutely right. PVT basically stands for the word pulseless ventricular tachycardia. And now he says like, what are you gonna do in this case? So let me just wait for a few more comments. Yes, guys, hit the comment button. Pulseless ventricular tachycardia in the casualty. What are you gonna do? I'll not like do check the pulse of the patient is already in intensive care unit. If the ECG itself is showing a VT with that broad QRS complex and a Josephson sign, then I'll not waste my time checking pulse in this patient. Absolutely, yes. So I think most guys are getting it correct. It's only fight between B versus C that is going on, and the correct answer will be that we'll not go for scene safety. Scene safety is for basic life support. Like suppose patient is on the road and somebody has collapsed, then we go for scene safety. But at the moment, it is not a scene safety. It is straight away start CPR in this patient. So the answer for this question would be option number B. Like he would anyway be unresponsive if patient has become pulseless. So the correct answer for the current question on the agenda would be answered as like start CPR, and subsequently a defibrillation needs to be done in the patient. Only if the question, yes, that's the main point, the patient is in the intensive care unit. In an intensive care unit, like checking scene safety doesn't matter, no, or checking responsiveness. Like the patients, if the ECG is showing a VT and you can see on the multi-para display monitor that the BP of the patient is crashing, that's when we write the word PVT. The BP is unrecordable. That's when we'll have to straight away go for defibrillation in this patient. However, if he's gonna be like if he's gonna be like a patient who was collapsed on the road, then it is obviously, verify scene safety and check for responsiveness. That's like the peripheral situation that would be coming. So just remember SRS, they'll ask you to arrange them in the correct order. Like if he's gonna be asking about basic life support, if he gives you a scenario that you are on the road, you went for a morning walk and somebody has collapsed, you are at the airport boarding gate and somebody has collapsed in front of you and they call you up, that is when you will check for scene safety. Like he could have fallen near electrical cables, he could have got electrocuted, he could be fallen near an escalator, and he could have injuries to his physical injuries to his body. So there it is verify scene safety. Then you tap the patient on the shoulder. Sir, can you hear me? You can touch his hand. Sir, squeeze my hand if you can feel me. and then shout for help. By shout for help, I don't mean I'm screaming my lungs out. I need more than one hand. And then what will you do? You will activate the emergency response. What I mean by activating emergency response is that you will be asking somebody who has come to assist you to call like 108 or whatever is the 102, whatever is the ambulance number, and because ultimately you need to transfer the patient to the nearest hospital, and then you will ask the person who has come for your assistance to procure AED. That is like automated external defibrillator. That's the main treatment that would be done in this case. So just get these steps right. SRS, AER, and AED would help in management of this patient. Dressler, okay, we'll discuss in MI now. We to MI aana hai, right? So just get the steps right. Procure automated external defibrillator for this patient. If you are supposed to evaluate this patient, would you first check for pulse, or would you check for, like, you ask the person to go and get the AD machine? Now what will you do yourself? Will you first check the pulse? Or would you be first checking for breathing? Okay, Shivam, that's a good question. Difference between cardioversion and defibrillation. I have explained that in a routine video, but I'll do it like once I'm done first. Exactly. We'll first check for breathing. Just follow the steps, guys. It is look for no breathing, and subsequently like check for pulse, and how a doctor will spend how many seconds in evaluating it. It is 10 seconds. And if both of them are absent, if there is no breathing, if there is no carotid pulsations present in the patient, that is when you would go ahead with institution of CPR for management of this patient. That would be in a ratio 30:2, and one cycle of CPR is for 2 minutes. So these are like simple steps in basic life support that you would have to remember for the patient. Also, I would like to say that if you are doing a intubation, then the number of breaths, how many breaths to be given once you've intubated. Though on peripheral scene it's not possible to intubate, but like suppose the patient was shifted to the hospital, or the ambulance came, and in the ambulance the facility for intubation was present, then like how many breaths would be given per minute to this patient, or like one breath every how many seconds? One is the doctor will use 10 seconds to simultaneously evaluate the carotid pulsation and the breathing effort. It would be one breath every 6 seconds. So the respiratory rate that we want to achieve is something in the range of 8 to 10 per minute. This is after advanced airway. That is at least advanced airway. That is one breath every 6 seconds is what we want to achieve. That would be 10 breaths that are needed to be achieved in this patient. And by the time the AED will come, and then we'll be putting the paddles on the chest of the patient. So please comment in the chat box while I make this line diagram before you, that in a person who is collapsed and you're putting the paddles of the AED, in which intercostal space would you be putting the paddle on the right hand side? This is like the left side of the patient. This is the right side of the patient. So the pads PADS, the pad of the AED will be put in which intercostal space? On the right hand side, the pad would be put on the second intercostal space. So one pad is put on the second intercostal space. It would be infraclavicularly, but your technical answer would be that it is manubriosternal angle, that is second intercostal space. That's where like the PAD, because एक paddles होते हैं और एक pads होते हैं. Paddles are for defibrillator and pads are for the AED machine. So one pad would be put in the second intercostal space. Can you tell me the position of the pad for the left? Yes. On the left hand side, it would be the fifth to the sixth intercostal space. Your answer would be it is between the fifth and the sixth intercostal space in the mid axillary line. The middle of the paddle, the left paddle would be put like, on this side, that is on the mid axillary line of the patient. So two paddles have to be put here, and both of them would be connected via wires to the automated external defibrillator. So what you can see here is just a crude representation that the AED will be deployed and the paddles are to be put in the positions that I mentioned before you. The computer will do a rhythm check, and then you just have to press on a button. It will deliver a DC shock that would be of intensity 200 joules. That would always be 200 joules biphasic. 200 joules biphasic. तो एक पैड होता है और एक पैडल्स होता है ना. पैड तो वो स्टिक ऑन वाला होता है ना, चिपका देंगे सिर्फ, राइट? यू जस्ट रोल द स्टिकर फ्रॉम द बैक, पुट इट ऑन द पैड. आई जस्ट शो इट टू यू. पैडल इज दिस वन, मैन. This is paddle. Paddle के लिए तो you'll require that insulation also, right? So if it is a defibrillator, the one that we use in the hospital, no, where you have to hold it, that is called as a paddle. That is PADDLE, paddle. Hold it in your hand and then you give a DC shock in the hospital premises. That is with respect to a defibrillator. But with respect to AED, that is automated external defibrillator, what you're seeing here is the pads, PADS, the pads that are being used, right? So it is like pads positions are what I have shown here at the moment. And then obviously this is an automated external defibrillator that would be helping us handle our patient. Now the question, paddle wala, because that is in the movies they show for paddles, because in the hospital premises though it is like a paddle wala only, no? Only in the outside scenario is a AED machine that would be used. Yeah, the positions and everything would be same. Yeah, nowadays we don't use monophasic ना बच्चे, monophasic वाला तो आजकल जितने भी AED है ना आजकल के, they're all programmed to use 200 joules biphasic. So 360 वाला तो मतलब मेरे मेरे जमाने की बातें हो गई, मतलब 20 साल पुराना क्यों जाना, अब तो लेटेस्ट ही पढ़ना है. Okay, ji, fine. So before we go to the next question, somebody asked regarding what is the difference between defibrillation and cardioversion, and that is what I'm going to explain to you. You see, the computer of the DC shock is taught to pick up the peak of the R wave. If the R wave will come, the computer will fire the DC shock. So if the computer is trying to read the peak of the R wave, if the computer is trying to read the peak of the R wave, that is when we use the word cardioversion. Or a better way to remember this would be the word synchronized DC shock. What I mean by sync mode is that the computer will try to sync with the peak of the R wave. But now check out this rhythm. Patient is having ventricular fibrillation. You can see twitching in the heart. If the twitching is happening, then the computer will get confused. We taught the microprocessor of the computer to pick up the peak of the R, and now there is no R wave. So the computer is bound to get confused. So in those circumstances where the peak of the R wave cannot be picked up, that is where we will be shifting it to a non-synchronized, we'll shift it to a non-sync mode. I mean, there's a toggle switch with which you can select a sync or a non-sync mode, and it's a non-sync mode that would be delivered, which is called as defibrillation. So if I put it in Hindi, I'll say that in both Hindi and English, defibrillation mein computer will not search for the R wave. If you press on the non-sync mode, computer will not search for the R wave, straight away firing ho jayega. But if it is gonna be you press on the sync mode, the computer will wait for the R wave to appear. So the decision in the advanced cardiac life support is made by the doctor with respect to whether or not should you be using a sync or a non-sync mode. The minimum that I expect you to remember at this moment is, yeah, yes. In Casino Royale, that's a very good example. They showed a AED. I mean, that was very funny, but then it's okay. I mean, the guy is giving himself a DC shock. That's crazy. Okay. That's a good observation, Anshuman. Defibrillation. I think you are a fan of action movies like any guys would be. Okay. So non-synchronous DC mode is defibrillation, and there are only two MCQs where you will be answering it as ventricular fibrillation. One is going to be ventricular tachycardia, second is ventricular fibrillation. English kar lo na yaar, defibrillation is used for ventricular fibrillation, and then is ventricular tachycardia for all other tachyarrhythmias. In all other tachyarrhythmias, it's going to be synchronized DC shock that would be used. Anshuman, just comment, did they use car batteries in that Casino Royale? I remember that scene where I think he was trying to hook it up with the car batteries or something like that, you know. So that is funny if they used car batteries to give a DC shock to an individual. Okay. So cool, guys. Basic life support is a good answer. Let's move on to the next one for today. The patient has had a ROSC, return of spontaneous circulation. And in those circumstances where there is a ROSC happening, he says, which of the following is a negative sense question? Which of the following is not correct about management of a post CPR return? Like you in the intensive care unit, the guy had a PVT, you ensured that the circulation comes back. He's gone back to normal sinus rhythm. Yeah. That is also funny. I saw that one. Mr. Bean also using that was really funny. Okay. Okay. Very good. Very good. You see, when we have post CPR return of spontaneous circulation, we want a mean arterial pressure of more than 65. Understandable. Oxygen saturation is 92 to 98%. That's what we want. And usually the cause of this can be MI. So we should also be going in for like a percutaneous coronary intervention. But there's a concept called as therapeutic hypothermia. We will deliberately decrease the temperature of the body so that the metabolism of the heart becomes lesser. And if the metabolism will become lesser, energy requirement will become lesser. And if the energy requirement will become lesser, the patient will be able to survive for a longer duration. You see here the problem in this question is it is written patient is not cooperative. You see, the point is targeted temperature management. I mean, the answer to this question anyway is option number A, because it's a recall anyway. You guys would have been able to solve it. But what I want to bring to your message is that it is done in those patients who are going to be like, you know, totally unconscious. So this is, yes. Yes, it is done in comatose patients. Absolutely, absolutely. So not in a cooperative patient. I mean, if the guy is having loss of cerebral perfusion, there would be brain damage, right? And because of the brain damage, the guy would not be in a position to cooperate. So good pickup, Leah Bhaumik, good pickup, Dr. Mahi. In this particular situation, the answer for this question is option number A. And this was a last time's INI-CET question. So what I've done at the moment is like I made it like I discussed a NEET PG question, I discussed an FMG exam question prior to that, easy one. So what I'm trying to do is a mixed bag so that you get like an idea of all of these. And just a suggestion, in case you have time at your disposal, I think there is time at disposal. So give a mock test. Make a habit of like doing these mock tests on a regular basis. That will ace up your preparation level. It's you see, yeah, the objective of doing a mock test is to hyper tune our senses, because we can't read everything, but we have to analyze. Sometimes you would know only three options out of four, sometimes you'll know two options out of four, sometimes you know only one out of four. But then should you answer that question where I know one out of four, where I know two out of four or not? That is what nobody can teach, right? I can teach you theory, but which question to leave and which question to attempt comes with self practice. Sometimes when you guess the question, it will go wrong. Sometimes you'll guess it, you'll get correct. Like my guesses always go wrong, so I stopped guessing, right? What I found subsequently was, because I'm not able to guess the correct answer, I started answering opposite of whatever I was guessing, and suddenly my score started going up. So you need to figure out a method, right? My guessing power is लाइफ ऑफ लर्निंग। बच्चे 32 से 35 डिग्री ना, उसको थेरापेटिक हाइपोथर्मिया बोलते हैं। हम आइस पैक्स यूज करते हैं ताकि बॉडी टेम्परेचर कम करके मेटाबॉलिक रेट को कम कर सके। थेरापेटिक हाइपोथर्मिया न्यूरो प्रोटेक्टिव भी होता है और कार्डियो प्रोटेक्टिव भी होता है, क्योंकि एनर्जी का जो रिक्वायरमेंट होता है बच्चे वो रिलेटिवली लेस हो जाता है। शुड मट ट्राई अ मॉक टेस्ट ऑफ INI-CET? Not exactly, doctor. For FMG exam there would be a separate one, no? So I think कर सकते हैं। देखो, इट्स ऑप्शनल। आई वुड नॉट लाइक टू से कि मैंडेटरी है, बट हाँ, अगर आप यू हैव ऑलरेडी क्लियर्ड वन एग्जाम एंड नाउ यू आर प्रिपेयरिंग फॉर नीट पीजी एक्सेट्रा, देन इट्स वर्थ रिकमेंडेड। ओके गाइस, moving on to our discussion, this is just a reference. The PDF of this will be available to you guys subsequently for revision. I would suggest you to revise this video subsequently also by downloading the video onto your device and revising it at 2x, right? फिर फास्ट कर देना स्पीड पे। अभी तो नॉर्मल स्पीड पे मुझे सुन रहे हो तो यू हैव टू एंड्योर मी, बट इसको एक बार दोबारा से जब सुनोगे ना तो यू विल बी एबल टू री एनफोर्स द इंफॉर्मेशन और द कॉन्सेप्ट्स दैट आई हैव सेड हियर, एंड सम पार्ट यू कैन स्किप आल्सो, द पार्ट्स दैट you are already aware of, so that would help you, help you method the that would help you understand the things relatively better. Okay, so next we'll talk about like ACLS, that is advanced cardiac life support, where there are three boxes which are to be remembered. They usually ask you these questions that the DC shock, doctor, in the description of the video only, there would be some PDF where you can like register for a PDF, or you can go into the app and register and the PDF would come to you, or you can drop an email at marwahmedicine@gmail.com and I'll be glad to share the PDF with you, even the blank one, so that you can annotate on it subsequently. Okay, sorted. CPR, like we have to give every time after DC shock. So every time we read about ventricular fibrillation, every time we read about Telegram group of PrepLadder, that's another way you can use it. Everywhere, man, this would come up, so you don't need to worry about it. Thank you, doctor. Thank you for lots of love and regards. In a case of ventricular fibrillation, there would be three boxes which are to be remembered, and usually the question will come like, after the first DC shock, what is to be done? After the second DC shock, what is to be done? And after the third DC shock, what is to be given? And it is gonna be like CPR, CPR, CPR. Dr. Pathus, follow these details very, very religiously. Follow these details very religiously. The ones that I'm discussing, BLS, ACLS is always asked. Three DC shocks are the ones that can be given. In the first box, you can see you are just securing IV line. Otherwise, you can use intraosseous access. Okay, the comments are going down. Quickly comment. Where would you put in which needle will you use to get an intraosseous access? Yes, guys. Quick comments in the chat box. Which needle will you be using for intraosseous access? And I mean, intraosseous access is obviously the lower extremity. Yes, in the tibia. Tibia बहुत बड़ा होता है ना, तो साइड बताओगे मुझे? 22 to 24 needle, 18 gauge needle. Okay, proximal tibia. Okay. So your answer would be that this would be, yes, it would be Jamshedi's needle here. Yes, bone marrow biopsy needle. So the needle that you can be using, see in America they have that portable gun. The bullet that is fired, it penetrates the cortex and reaches up to the medulla. So it's like a gun that is fired, but in India we won't have that facility. So we'll be using a Jamshedi's needle, and yes, it would be like a lateral to the tibial tuberosity. So your technical answer would be obviously tibia. But if he says where, then it is not exactly the tibial tuberosity. It is like a little lateral to the tibial tuberosity where we penetrate the needle and we get access to the bone marrow of the patient, and bone marrow has very good communication with the venous system. So it would be like Jamshedi's needle, tibial tuberosity, where we will be poking the patient for intraosseous access. And we'll anyway, the CPR is continuing. If the patient reverts to normal sinus rhythm, great. If it not, then the second DC shock would be given. So this is second DC shock being given, after which CPR is being given, and then we are giving epinephrine to the patient. The concentration of epinephrine that we give is standard, that will be 1 milligram, 1 is to 10,000, and this is being given because we want to increase the responsiveness of the electroshock. We will also intubate this patient at this particular point of time, so the number of breaths to be given will be like 1 breath every 6 seconds or 10 breaths per minute. If in spite of 2 shocks is not improving, the third and last shock that we give is for followed up with amiodarone or lignocaine, that would be given to this particular patient. And absolutely, like I think everybody got it spot on, that these details that we're discussing is for advanced cardiac life support, where these 3 sequential steps are asked per se. For ventricular fibrillation and a pulseless ventricular tachycardia, if he says what is the type of DC shock that is given, what we've learned is it would be a non-synchronized DC shock. And how many DC shocks are given, then it is total of 3. But if I change the question to the right hand side for cardiac arrest, if it is a cardiac arrest or a pulseless electrical activity, Shivam, intraosseous in sternum will be very risky now for somebody, like, honestly speaking, even trauma guys. No, I'll speak to a trauma guy, since you said why not give sternum. But I think it's too risky to insert it in the sternum. If it goes too deeper, it can contribute to a damage. Even if you're using a guard, right, there's a possibility of causing trauma to the patient. So I think lower extremity would be a better answer. When it is going to be a non-shockable rhythm, then it's even much more easier. Epinephrine, asystole or pulseless electrical activity. Examples of pulseless electrical activity can be like cardiac tamponade. Example of pulseless electrical activity can be like tension pneumothorax, for which specific managements are required. But in all of these patients, the first line intervention would be epinephrine and followed by this anyway CPR. If in the MCQ ASAP word is not given, then first answer CPR. For all MCQs, answer is CPR only, as we discussed in the previous question only. If epinephrine ASAP is not given, then answer is CPR followed by epinephrine to be given to this patient. And after getting an IV access, there is no rule of DC shock in a flatline ECG. Like this guy had a myocardial infarction, ST elevation MI, and then he became flatline. So what we will do is repeat adrenaline shots. There is no limit to the amount of adrenaline shots that can be given to this patient. So it is repeat adrenaline shots. Okay, Dr. Medico, I'll do that. It is repeat adrenaline shots that would be given for this person, so that we can convert this into ventricular fibrillation. क्यों बार बार adrenaline लगाते हैं? The reason why we give adrenaline repeatedly is to convert a asystole into ventricular fibrillation. And the moment you will convert it into ventricular fibrillation, you can be giving a DC shock to the patient. But we don't give DC shock in a flatline ECG. The main reason why I went into the right hand side of this patient is that the DC shock of the patient, sir, वो soldier नहीं हो सकता ना फिर. In a patient who's coming to a crashing patient, and like most of the time, most patients who coming to us, amputation bilateral भी नहीं होगी, है ना, unlikely है ना. तो मतलब extreme situation के बारे में क्यों सोचना? Most of the time the cases that we get, patients going into arrhythmias are either gonna be like old people with a heart attack. That is one possibility. और amputation भी जो होती है ना, मोस्टली वो टोज की होती है. लाइक मान लो सोल्जर भी था, टोज की amputation है, फुट की है, तो मोस्टली सोल्जर्स में amputation बिलो नी या अबव नी वाली तो बहुत लेस लाइकली होगी. Maximum number of DC shock that can be given is 3 only, doctor. Like you can see, I put three star marks here. This is DC shock number 1. This is DC shock number 1. This is DC shock number 2, and this is DC shock number 3. But DC shock is absolutely contraindicated with respect to a flatline ECG. Can you comment in the chat box for any other contraindication for DC shock? Waiting for answers. DC shock is contraindicated in a case of asystole, is what I have already said. Can you tell me any other condition where DC shock would not be given? Asystole and pulseless electrical activity is anyway mentioned. There is no role of DC shock in which of the following? Yes, guys. Yeah, pulsus electrical activity, understandable. That is understandable. Any other situation which is a complication of myocardial infarction? ओके वेरी गुड मल्टीफोकल टैकिकार्डिया बट उसमें भी यार अगर बीपी क्रैश करेगा तो लास्ट रिजॉर्ट तो देना पड़ेगा ना बट इवन इन मल्टीफोकल टैकिकार्डिया वी माइट हैव टू गिव उसमें मैंने बोला डीसी शॉक इज नॉट रिकमेंडेड बिकॉज ऑफ द रेकरेंस ऑफ एरिथमिया बट द टेक्निकल आंसर हेयर वुड बी व्हाट इज कॉल्ड एज इलेक्ट्रोमैकेनिकल डिसोसिएशन व्हाट आई मीन बाय इलेक्ट्रोमैकेनिकल डिसोसिएशन इज अ कॉम्प्लिकेशन ऑफ मायोकार्डियल इंफार्क्शन वेयर द हार्ट विल बर्स्ट यू सी उसको हार्ट अटैक हुआ इट वाज कॉजिंग सो मच ऑफ ट्रांसम्यूरल myocardial infarction. It is so much of transmural myocardial infarction occurring that the heart has subsequently burst on the third or the fourth day. And the technical term that we use for that, if the heart will burst, even God will not be able to save this guy. That is called as electromechanical dissociation. The meaning, simple English meaning of the word electromechanical dissociation is a cardiac rupture. This can usually occur on day 3 or day 4 with respect to post myocardial infarction in a patient. Yeah, one complication can be MI, can be LV aneurysm, but then again, if there's an LV aneurysm, a small one, I can be giving a DC shock in a patient. But these are like 3 situations where like we are not gonna give DC shock. And one doctor said multifocal tachycardia. Doctor, your point is correct, totally spot on, you are right there, but I'm just modifying what you are saying by saying that DC shock is not recommended in multifocal atrial tachycardia, not because of the fact that it's contraindicated, it is just that the arrhythmia will tend to reoccur. So I would like to treat the COPD of the patient for multifocal atrial tachycardia. ECG finding of electromechanical dissociation would be electrical alternates. The doctor said, what will be the finding of electromechanical dissociation? Because when the heart will burst, then the blood will pour into the pericardial space. And when blood will pour into pericardial space, it will cause cardiac tamponade. It will cause a hemopericardium. So the ECG finding of this patient will be electrical alternance. So that's the peculiarity. With electrical alternance in this patient, the pulse of the patient will begin to disappear. That's the ECG finding that would be coming in this patient, electrical alternance. Doctor, for combined medical services, no, they ask a lot of data from cardiovascular system, neurology that I'll be discussing. So I think this session will be highly productive for you because they keep on changing the questions every year. So even if you're doing those previous year questions, it would help. But then listening to this core information would make you more capable of handling all these aspects. The ECG finding of electromechanical dissociation would be that of like a very good question that came up would be answered as electrical alternates. Okay, cool. So we are now going to talk about arrhythmias, and the first arrhythmia that I'm going to describe before you is having a variable RR interval. There are two ECGs in which you will always be getting is a variable RR interval. One is multifocal atrial tachycardia, second is atrial fibrillation. Most MCQs of this topic will always begin by describing an alcoholic and may also mention that this guy went for binge drinking. And then what you will notice is that there would be absence of P waves in this patient. As you can see in the irregular RR interval, there is no presence of any P wave present in this patient. Yeah, holiday heart is one possibility. So the correct interpretation for the first ECG that you see at the moment is atrial fibrillation. This is one of the most common sustained arrhythmias in clinical practice. Now the problem in atrial fibrillation is that there could be twitching of the atria that can cause clots. Because there can be clot formation, I can either be going in for echocardiography to visualize the clot, or I can be using a scoring pattern that is called as CHAD S2 VSC score to decide for the need for anticoagulation. I mean, how do you decide the need for oral anticoagulation? Either we will base it on transesophageal echocardiography where I can see the clots, but even if I like transesophageal echocardiography will require like, you know, more intense I mean, at least the patient needs to be admitted, right? On a OPD basis, at least we can do a transthoracic echocardiography. If we can see the clots, it is cool. Otherwise, we can use the scoring pattern to start the patient on oral anti-clotting drugs. He will use the word VAF. VAF means valvular atrial fibrillation. Valvular atrial fibrillation is the one that is seen in India with rheumatic heart disease with mitral stenosis. And the drug that should be used in this case is warfarin. And the target INR of this patient should be kept between 2 to 3, as I mentioned. But if he says the word non-valvular atrial fibrillation, if it is non-valvular atrial fibrillation, Then it is the newer oral anti-clotting drugs that would be used for this patient, that is like apixaban. And in case he talks about recent onset, this was FMG exam question last time. This was FMG January question. Recent onset atrial fibrillation with hypotension. If atrial fibrillation is of recent onset, definition of recent onset is within 48 hours, then there are no clots. If there are no clots and the BP is unrecordable, then you can straight away go ahead and give a DC shock to the patient to treat the patient. But if it is long-standing atrial fibrillation with hypotension, in NEET PG, they have always asked long-standing atrial fibrillation with hypotension. In long-standing atrial fibrillation, because there is presence of clots present in this patient. In long-standing atrial fibrillation, because initially तो heparin तो दे ही सकते हैं ना डॉक्टर साहब. Shivam, like you put up a question, I can initially anyway give heparin to the patient. No, even if I'm having issues with any other drug and there is like a severe compromised GFR in a patient, heparin anyway has to be given initially for the patient so that I can at least prevent the acute onset events that are occurring in this patient. So, okay, if it is long-standing atrial fibrillation, then because there is presence of clots, in those circumstances, what we will use is RACE protocol, where we'll be using esmolol in this patient. Along with esmolol, we'll also be using anti-clotting drugs that I mentioned. Then we will be giving amiodarone to the patient for chemical cardioversion. And if there is no improvement with amiodarone, then subsequently a DC shock can be given even in this case. But the point is, RACE protocol is valid for R is for rate control, A is for anticoagulation, C is for chemical cardioversion, and E is for electrical cardioversion. That is mainly to be remembered for whenever there is a long-standing atrial fibrillation. Now I will discuss two more MCQs, one of NEET PG 2024, another one of NEET PG 2023 with respect to atrial fibrillation again. What he will do in both INI-CET and NEET PG is that he will put up a question of atrial fibrillation and he will mention that the patient is in acute heart failure. Now he will not write the word acute heart failure, he will write bilateral crepitations in the chest. If the question will mention acute heart failure in the options, like he will say in the description bilateral crepitations in both the lung fields, then do not answer esmolol, because beta blockers are contraindicated in acute heart failure. That is when the answer will be given as digoxin. So somebody commented digoxin, that is answer only to be given in a question when there is heart failure given. This concept has been asked in INI-CET and NEET PG again and again. And then in 2023, he mentioned that the atrial fibrillation patient is having asthma, which is poorly controlled. So again, beta blockers are contraindicated. And in those circumstances, I can be using calcium channel blockers in this patient, that is verapamil for this patient. Now we'll come to a question, like I'll say this once again, yeah, verapamil or diltiazem can be used for the patient. I'll answer that query of recurrent में क्या करेंगे, चलो मैं यहाँ लिख ही देता हूँ. अगर किसी पेशेंट को रिकरेंट एपिसोड्स ऑफ एट्रल फिब्रिलेशन हो रहे हैं तो हमारे पास में दो ऑप्शंस हैं. एक ऑप्शन है कि वी यूज लेजर बीम टू डिस्ट्रॉय द कार्डियक टिश्यू from where the current is generating, that is catheter ablation. That is, we will do electrophysiological studies, and after electrophysiological studies, catheter ablation will be done in a patient. The second option that I have is to put in a implantable cardioverter defibrillator. If a person is having a documented structural heart disease like cardiomyopathy, like alcoholic cardiomyopathy, then we'll put in a implantable cardioverter defibrillator. But there is no documentation of structural heart disease, then it is catheter ablation that can be done in a patient. So let's look at the gradation of the questions. FMG एग्जाम में उसने बहुत आसान पूछा. उसने बोला रीसेंट ऑनसेट एट्रल फिब्रिलेशन है. मैं रीसेंट ऑनसेट एट्रल फिब्रिलेशन में तो क्लॉट्स बनते नहीं है, क्योंकि क्लॉट्स को बनने में तो टाइम लगता है. सो इन अ रीसेंट एट्रल फिब्रिलेशन, then the answer is you can straight away give a DC shock because BP is unrecordable. But if it is long-standing atrial fibrillation due to hypertension, due to any of the other situations, before you answer esmolol, just check out in a question, because since you guys would be sitting for INI-CET very soon, and then subsequently some guys for NEET PG, then subsequently guys for FMG exam, so keep a watch for these two facts that I'm highlighting कि heart failure तो नहीं दे रखा, asthma तो नहीं दे रखा. वो ऐसे मतलब सीधा नहीं लिखेगा acute heart failure. He'll write like bilateral crepitations are felt in both the lung fields of a patient. Third heart sound is present. Elevated JVP is present. He will give you findings of congestive heart failure in a question of atrial fibrillation. If findings of congestive heart failure are given, if acute pulmonary edema is given, don't answer esmolol is the message. If he says asthma, then it is much more easier, I think, than it is verapamil that would be used. If it is on a recurrent basis, then catheter ablation or implantable cardioverter defibrillation, which is to be used. Yeah, we can use dabigatran also ना. यहाँ पे वो तो सारे नए वाले हैं ना. apixaban, dabigatran, those are like the newer drugs that can be used for management of these patients. तो क्लोपिट्रोग्रल तो यार इंडियन पॉपुलेशन में बच्चे देते नहीं है ना, जैसे किसी ने मेंशन बोला इबुटिलाइड, हाँ बच्चे, पर पहले तो एमिड्रॉन इजीली अवेलेबल है ना, एमिड्रॉन को हमेशा पहले आंसर करना ओवर एंड अबव इबुटिलाइड। देखो मतलब आइडियली तो देखो फैंसी प्रोडक्ट्स बोलने चाहिए, बट कॉमनली तो हमारे अस्पताल में जो अवेलेबल है पहले उसको बोलेंगे ना बच्चे, तो योर फर्स्ट आंसर वुड बी एमिड्रॉन एंड देन सब्सिक्वेंटली यू कैन आंसर इबुटिलाइड फॉर दिस पेशेंट। Okay, okay. IVC filter for this one, doctor, will not be working. IVC filter is used in those cases where there's a recurrent pulmonary embolism occurring in a patient. No, if there's patient having recurrent clots going from the deep vein thrombosis to the heart, that is where IVC filter will be used for this particular patient. Okay. Okay, fine. I think I addressed most of the queries there. Yes, beta blockers are not to be given and digoxin is to be used. That's only in a situation. There the DC cardioversion followed by thrombolytics. Anshuman, can you just comment on this part again or send me an email regarding the case that you were discussing, because patient might have had a myocardial infarction. Na? So in a myocardial infarction, you anyway have to, give thrombolytics to the individual. But anyway, Anshuman, do let me know regarding the case that you were talking about. Otherwise, for atrial fibrillation, that's the algorithm to be used for recent onset or a long-standing atrial fibrillation. Anyway, like thrombolysis का तो कोई rule नहीं है ना. There is no thrombolysis to be done for case of atrial fibrillation. Okay, moving to the next question. Again, a hot favorite with our examiners. Here also, he will give you irregular RR interval. You can check out the RR interval in this patient is varying. Once again, considering that there is a variation in the RR interval, I will check for the P waves. Now, if I zoom it here, what you will notice is here it is like a P wave, yes, coming in, but the size of the P wave is different from the second one that I have shown, or the size of the P wave is much more different from the P wave that is preceding it. So what we are having in this case is multifocal atrial tachycardia, MAT. MAT stands for multifocal atrial tachycardia. This is called as MAT, guys, multifocal atrial tachycardia. And the hint of this question will mostly be COPD patient presents with palpitations and syncopal attacks. The moment I say COPD, for the rate control of this patient, I cannot be using beta blockers. So it is here calcium channel blockers like verapamil and diltiazem will be used for this patient. In multifocal atrial tachycardia, our objective is to treat the COPD of the patient, and therefore quick comments in the chat box with respect to what treatment is given for COPD apart from long-term oxygen therapy. I mean, obviously, we will give oxygen to the patient, long-term oxygen therapy using a oxygen concentrator. But then quick comments in the chat box. What is the treatment drugs that you'll be using in COPD? Can you tell me the longest acting beta-2 agonist? Can you tell me the name of LABA, longest acting beta-2 agonist? Yes, guys. Waiting for your comments. Which of the following? Okay, I'll not give examples then, right? I'll not give examples then. Okay. Can you tell me the name of the longest acting? Okay, salmeterol, formoterol. Okay, so Dr. Basak was spot on. Yes, Dr. Shreyashi. It is indacaterol that would be given. That's a long-acting beta-2 agonist that will be working for like almost 24 hours. So I just wanted to test your knowledge of pharmacology by mentioning regarding LABA that would be given to this patient. We'll anyway be using LAMA in this patient. LAMA can be like tiotropium, glycopyrrolate. There are so many of them that can be used, and along with this, what we will also use in inhaled corticosteroids that can be like budesonide, beclomethasone, a whole host of these drugs which are available. But then we need to treat the hypoxia, guys. We need to treat the hypoxia of COPD, because hypoxia will cause pulmonary artery hypertension. It will cause right ventricular hypertrophy. You know the story. So I'll just write it quickly here. I mean, there is a hypoxia in COPD patient. Hypoxia will cause vasoconstriction of the pulmonary artery, causing pulmonary artery hypertension. This pulmonary artery hypertension will cause right ventricular hypertrophy, and because of the hypertrophy of the heart, there would also be damage to the right atria, and because of the damage to the right atria, there can be creation of this arrhythmia that is called as multifocal atrial tachycardia. The definition of multifocal atrial tachycardia will be that there will be a variable RR interval, as you can see, and along with variable RR interval, the P wave amplitude in this patient will also be variable. There are two things that I've said variable here. One is gonna be P wave amplitude that is variable, and second is RR interval. So now you know two conditions where there's a variable RR interval, atrial fibrillation and multifocal atrial tachycardia. Just check the presence of P wave. If P wave is absent, it is atrial fibrillation. If it is present with a variable amplitude, as I've shown, the size is varying, man. I mean, look at the pointed P wave, look at the shorter P wave, look at almost a flattened P wave. So because the morphology, the P wave is totally different. The morphology, the amplitude is totally variable. We call it multifocal atrial tachycardia. And DC shock, doctor, again, you used my favorite word, buster medicine. I love that, right? But DC shock contraindicated नहीं बोलना, उसमें बोलना DC shock is avoided in this condition because of recurrence. कॉन्ट्राइंडिकेटेड वर्ड थोड़ा सही नहीं लगता है, तो बोलेंगे डीसी शॉक इज नॉट रिकमेंडेड इन दिस कंडीशन बिकॉज ऑफ द रेकरेंस, क्योंकि आप दोगे भी तो एरिथमिया दोबारा चालू हो जाएगा बिकॉज ऑफ द हाइपोक्सिया कंपोनेंट व्हिच इज प्रेजेंट इन दिस पेशेंट. Inflammation, Gautam. Inflammation, Dr. Gautam, you said like airway inflammation is a feature that is seen in COPD also. There you are having a lot of lung secretions present. Those lung secretions will obstruct the airway. That is why like we will use inhaled corticosteroids. Then the next ECG which is present here, yeah, roflumilast can be used subsequently. Like that's like a step up that we'll be using in gold classification. We'll talk about gold classification in part 2 of our discussion. Okay. So what you can see next is those flutter waves which are present, and because of these flutter waves, we are having that sawtooth pattern that is seen with the atrial flutter. So the next arrhythmia, I'll just do an ink change for this so that I can get the contrast going, is atrial flutter. And the treatment for this condition is same as that of atrial fibrillation. So we'll still go for rate control, anticoagulation, amiodarone, and then DC shock. But then the intensity of DC shock that is used in this condition is the lowest intensity of DC shock that would be used. That is 25 to 50 joules is the lowest intensity of DC shock that would be used for these patients. Once we get this right, we'll next focus on the next arrhythmia, which is a narrow QRS tachycardia. You can see a narrow QRS tachycardia with the ST segment depression coming up, and then there are hidden P waves. The features that are shown before you is hidden P waves. What I've also shown before you is a narrow QRS complex with the RR interval in this patient being substantially reduced. Considering this would be a supraventricular tachycardia. This is a paroxysmal supraventricular tachycardia. Question putting up to you guys, what is the best treatment for paroxysmal supraventricular tachycardia? Yes, stable vagal stimulation, unstable DC shock. Okay, let's be a little more aggressive. Okay, adenosine. Okay, but adenosine will not cure it, right? DC shock will not prevent the recurrence. Adenosine and vagal maneuvers will not be preventing, right? So if he says what is the best treatment for PSVT, it is the reason for PSVT, remember, is a re-entry phenomenon. No? The question is on prevention, guys. The question is on prevention. Exactly. Dr. Ram got it spot on. What we will do in this patient is a catheter ablation. The best way for treatment of all arrhythmias is to prevent the recurrence of these arrhythmias. It is a catheter ablation. A patient is not ready for catheter ablation at the moment. To prevent the episodes from occurring, I can be starting my patient on a calcium channel blocker like verapamil. So it is catheter ablation and verapamil which would be answered. Baki, the remaining answers would be if the patient is hemodynamically stable. Then in those circumstances, it is vagal stimulation first, using a carotid sinus massage followed by administration of adenosine. And after giving adenosine, we'll be giving a saline push to the patient so that the drug can reach up to the heart, because the dose we are giving is 6 milligram, and then maybe if required 12 milligrams subsequently. But if the patient is hemodynamically unstable, then I will not be wasting my time for giving vagal stimulation and adenosine for the patient. I will straight away be going ahead with a synchronized DC shock. So there are 3 domains that I've covered here. One is for prevention. Second is for acute presentation. In acute presentation, we have divided the discussion into 2 parts, stable and hemodynamically unstable, and most questions revolve around this also. Narrow QRS hypokalemia. No, doctor, absolutely not. Hypokalemia will be having a T wave inversion. It will be having a PR prolongation. It will be having ST segment depression. So the findings in hypokalemia would be Valsava we can try. Absolutely, Uttam, we can use. Yes, calcium channel blocker in case of adenosine. Shivam, you're right. If it is an asthmatic, we can use calcium channel blockers. Verapamil anyway, it will block the AV node of the patient. The next situation or the next arrhythmia that I'm dealing with you is having super broad QRS complex, right? With that very characteristic notch that is being present. So what you can see in the ECG of this patient is a broad RS complex tachycardia. And along with this broad RS complex tachycardia, you are also noticing a small notch that is coming up, which is called as Josephson sign. Even if you don't remember Josephson sign, the main word to be remembered is every time there's a broad RS complex tachycardia, you are going to label that as VT, that is ventricular tachycardia. And since all these are of equal size, you can see the vertical height of all of these is same. So you will say the word monomorphic ventricular tachycardia. In a question of monomorphic ventricular tachycardia, again, if we say stable ventricular tachycardia, the BP is holding, it is amiodarone. Amiodarone is a broad spectrum antiarrhythmic drug that can be used in a patient. Otherwise, we can use beta blocker also. Like I don't have amiodarone at the moment, I can be using beta blocker like metoprolol to control the fast beating heart rate. But if it is a pulseless ventricular tachycardia, then it is DC shock that would be given. It's a non-synchronized DC shock that should be given to this patient. If it is a pulseless ventricular tachycardia, it's a non-synchronized DC shock. That would be total of 3 DC shocks that would be given. Great comments coming guys. You need to keep on commenting, right? So that you can remember all these small nitty-gritties. And these questions are very super easy, man. Super easy. There are only like hardly 6-7 concepts to be remembered, like irregular RR interval with absence of P wave, presence of P wave, presence of atrial sawtooth waves, narrow QRS tachycardia versus a broad QRS tachycardia. Those are like ultra easy concepts guys, which are very scoring. And PSVT में नहीं हुआ बच्चे, we don't use amiodarone in PSVT because we need to act on the AV node ना. Amiodarone acts on the cardiac muscle, not on the AV node. Amiodarone, the main mechanism is the drug works on the ectopic focus in the muscle and it slows down the firing frequency of the ectopic focus. So it will not block the AV node. That's why. Yeah, the intensity would be uniform 200 joules biphasic. Okay, so moving ahead, guys, pulseless VT में, yeah. We'll be using a DC shock in a patient. PSVT plus asthma, calcium channel blocker, Dhanushri. I hope I've answered you. Very good. So you are getting a question now, which is having again a broad QRS tachycardia. But at the same time, this broad RS tachycardia is having a variable amplitude. Because of this variable amplitude, we are going to call it a polymorphic ventricular tachycardia. And considering a polymorphic ventricular tachycardia, the drug that we'll be using in this patient is magnesium sulfate. That is a separate thing, that if this patient is also having an unrecordable blood pressure, then I'll go ahead with DC shock only, a non-synchronized variety. But from the drug perspective, it is magnesium sulfate that would be given. And usually the trigger responsible for this can be electrolyte imbalance like hypokalemia and hypomagnesemia. So every time you get a question on electrolyte imbalance and arrhythmia coming up, then hypokalemia, hypomagnesemia, or drug toxicity. Drugs could be like hydroxychloroquine. Drugs could be like cisapride, estamizole. So if they give you drug toxicity, like in NEET PG, I think they put up a question on estamizole, or I think it was on terfenadine, but these are like banned drugs, cisapride, estamizole, terfenadine. Hydroxychloroquine is not banned, it is used, but then it can cause a prolongation of the QT interval and it can cause a development of yes, even class 1 and class 3 antiarrhythmic drugs also. Yes, Siddharth, you are perfectly right for that. Even class 1 and class 3 antiarrhythmic drugs can be contributing to it. So magnesium sulfate would be used as the drug of choice. And the last one is super easy. That would be ventricular fibrillation, about which I've already spoken about, where there would be a twitching activity. Most scenarios of ventricular fibrillation will originate from either football player dying suddenly, or it's going to be myocardial infarction patient crashing in the casualty, where ventricular fibrillation and the treatment for the same would be working. PIH में, how does it work? Magnesium is an antagonist of calcium, no? So it will antagonize the effect of calcium, and therefore calcium causes vasoconstriction. So it will relax the blood vessel. So PIH is pregnancy-induced hypertension, vasoconstriction. Magnesium is an antagonist of calcium. It will antagonize the effect of magnesium, and thereby the good thing would be that the effect of vasoconstriction will go away and the blood pressure will relax. The key word is magnesium is an antagonist of calcium. Okay, fine. Moving ahead. We are now talking about a bradyarrhythmia, and I would like you to, I'll just count the heart rate of this guy. This is like 7, 8, 9. So the heart rate of this patient would be 300 divided by 9. That would be less than 40 beats per minute. Yes, guys. Heart rate of only 40 beats per minute. If you check out the PR interval of this patient, this is a P wave. I'll draw a P wave here. This is a P wave. Prior to that is a T wave. The green that I'm showing is a like a T wave inversion that is coming up. So this was a T. Then subsequently I've shown a P wave here. This is another P wave. Let me just get the colors right so that I can emphasize the information before you. So you can see our inverted T wave. I think everybody can, I'll do it once again. This is the inverted T wave I'm talking about. And after that in blue color, you're seeing two P waves present. This is one of the P waves. This is the second P wave. Right. And you can check out the PR interval. The PR interval in this patient after and before the missed beat. The PR interval in this case, before and after the missed beat is the one which is to be checked. Let me put appropriate colors so that we can get this data right. Keep the comments going, guys. Keep the comments going. The PR interval after, and because you can see a P followed by a P. Here, there's a drop happening here. There's a drop happening here. I'll draw the vertical arrows for the drops. So because I'm saying drop beats, either it will be Mobitz 1 odd block, or it will be Mobitz 2 odd block, or it will be a 2:1 block. I repeat my statement. If I say drop beats in a question, the heart rate is slow and I'm saying drop beats in a question, either it will be Mobitz 1 odd block, or it will be a Mobitz 2 block, or it will be a 2:1 block. There can only be three possibilities in a question. In a Mobitz 1 block, there is a prolongation of PR interval. So the answer to this cannot be Mobitz 1. Now we are left with only two, Mobitz 2 odd block and 2:1 block. So I would like you to now compare this ECG that I'm now making before you, where the PR interval is normal. It is normal. It is normal. It is still normal. And then after T, you can see a P and I'm waiting like a sinus pause that is coming. And you are noticing that there is a drop beat that is coming in this patient and there was a drop present. And then once again, the restoration of activity is occurring. So guys, what I want to bring to your attention is that before you answer Mobitz 2 heart block in a MCQ, check out the fact that is it happening that it is alternate conduction and non-conduction versus multiple conductions and then a drop. The answer to this question, a difficult one for today, is what is 2:1 block. 2:1 block is a differential diagnosis of Mobitz 2 heart block. The first thought process of yours should always be check out the PR interval after and before the drop rate. It was equal. So it is, first answer is Mobitz 2 heart block. But if you check out, I'll put markings now. This is the conducted P wave, where I put the arrows, conducted P wave. So QRSV aa raha hai or TB aa raha hai. Then I'm saying that the person is having, let the green go off. It is a non-conducted P wave, where the P is shown, non-conducted P wave. Then again I'm putting marking conducted P wave, let it go off. Now is a non-conducted P wave. अगर alternate चलता है, conducted, non-conducted, we call it a 2:1 block, which is a differential diagnosis of Mobitz 2 odd block. Mobitz 2 odd block का जब वो ECG देगा ना, उस पे PR will be normal. And will be normal, and will be normal, and will be normal. So it is like normal, and intermittently there would be drops present, and again the rhythm will be normal. So the common thing is obviously drops, the drops that are occurring alternatively. That is what you call as a 2:1 block, which is a differential for Mobitz 2 odd block, which I want to basically explain to you. So I think that this is like a important ECG, especially from the perspective of the forthcoming exam. The first one on the block is gonna be INI-CET, so that's a favorite of those. Mobitz 1, Mobitz heart 2, nobody will mistake. I'll do a quick representation for Mobitz 1 also. You can compare on a visual scale only. I have increased the PR interval. I'm gonna increase the PR interval even further. I'm gonna increase the PR interval even further. So I don't think so that Mobitz 1 ever can be a challenge for anybody, because if you check out the PR interval the first time, the second time, the third time, the fourth time, it's gonna show a serial increase. But if the PR interval is normal followed by a drop, it is Mobitz 2. So this was I think a good pickup by a lot of people who answer 2:1 block spontaneously. But I'll say now compare the three ECGs together. Mobitz 1 तो clear हो गया ना यार. Prolongation of the PR interval is Mobitz 1 odd block. Mobitz 2 में क्या होगा? It will be multiple normals, multiple conducted followed by non-conducted. Multiple, the word is multiple conducted P waves followed by non-conducted waves. Multiple conducted, non-conducted. यहाँ पे alternative चलता है. In 2:1 block, guys, it is alternatively conducted P wave, non-conducted P wave. Alternatively conducted P wave, non-conducted. If it is alternatively running, then you are gonna say it is 2:1 block. If it is gonna be like multiple normal conductions, multiple आ रहे हैं और फिर एक drop आ रहा है, that is when you call it Mobitz 2 heart block. So this is what I would like you to remember at this moment, guys. Otherwise, like what I would suggest is listen to this in the rapid revision segment as well, where like I have given much more time to this here at the paucity of the time that I have at my disposal. I think I'll be able to explain this again. So Shubham, I think I was able to explain this, but then if it is not present, then this is a common aspect to be remembered. In 3:1, guys, they would be like 2:1 basically is a term that is used when alternative, one conduction and then one non-conduction is present. If it is gonna be like one conduction and two non-conducted waves, then it becomes like a 3:1 block that would be occurring. So there would be two waves, P waves present in between that. Okay, fine. Let's move ahead to the next one where they have given myocardial infarction. They've given an ECG of myocardial, like he began by describing classical Levine sign in a patient with sweating, etc. So we knew that he's describing a myocardial infarction, and then he's given this ECG. If you scroll through the ECG, lead number 1, not significant changes. Lead number 2, lead number 3, I can pick up a bit of like, ST segment elevation. In lead number 3, I can pick up a bit, but not in lead number 1 and 2. But that means that I am not being able to pick up anterior wall myocardial infarction, because what you are checking out in this ECG. Yes, guys, keep the comments coming for which surface of the heart is involved in this particular case. And what you are noticing in this chap is a ST segment depression. What you are noticing in this guy is a ST segment depression with upright T wave. You can see upright T wave. I'll just zoom it in. I'll just erase it and do this activity once again. In lead number V2 and V3, there is a horizontal. Normally, whenever I draw ST segment depression, it's always like this. Whenever I draw T wave inversion, whenever I draw ST segment depression, now it is always going to be having a curvature around it. But you can notice in the current ECG that I'm drawing, it is a horizontal ST segment depression with the upright T wave that I've shown in lead number V2 and lead number V3. This is a little difficult one in a sense that the ECG findings are present in V2 and V3 and bit in lead number lead number V4 also. So there can be two possibilities in this question. Either this is going to be a non-ST elevation MI of the anterior wall. That is one possibility. Non-ST elevation MI of the anterior wall. That is possibility number 1. Second possibility is that the person could be having a posterior wall myocardial infarction. Now, how do I differentiate between the two? Differentiation is one possible by putting special leads like V7, V8 and V9. If V7, V8, V9 will show reciprocal changes, then I will say posterior wall MI. Otherwise, I will say non-ST elevation MI of the anterior wall. But if this V7, V8, V9 is not given, then how would you pick up in a question is the word what I was saying verbally, and I drew it also, that is a horizontal ST segment depression. In myocardial infarction, you will always have a convexity present, but if you're having a horizontal ST segment changes present. This is a horizontal ST segment depression and an upright T wave which goes in favor of a posterior wall myocardial infarction. So initial impression of mine was this is non-ST elevation MI. The conventional way to differentiate between the two is to look for lead number changes in V7, V8, V9, which is posterior leads. But because those were like not given in the exam, so the key word to be picked up is a horizontal ST segment depression along with presence of upright T wave, especially with respect to lead number V3, and therefore the answer for this particular question would be given as posterior wall myocardial infarction. I agree that the previous two ECGs that I've given have been relatively more difficult than the traditional ones, but I'm trying to prepare you for like even if they give you whatever, like even if the hell breaks loose, I am trying to make you up, gearing you up to handle those challenges. Now we'll be focusing on the next ECG, which is much more easier, and I expect spot answers here. Again, Levine sign present. You can notice a bit of T wave inversion in lead number V3. Meanwhile, some part of the inferior surface is also having a ischemia. There is a T wave inversion in lead number 3. Quick comments, guys. I would like everybody to hit the chat button simultaneously. What type of myocardial infarction is shown here? The changes are seen in V1 and in V2 and in V3, right? And okay, so not significant in V4, V5 and V6, but at least like V1, V2, V3, yes. Yes, anterior wall MI, and because V1, V2, I can call it septum also, no? Because V1, V2 will be involving the septum part. So your answer is right, anterior wall MI. I would just like to modify by saying this is an anterior septal. I added the word, even if you said anterior wall MI, it is okay. Even if you said anterior wall MI, it is okay. But I just wanted to bring to your attention that lead number V1 and V2 especially studies the septum also. So anterior septal myocardial infarction will be a much more better answer. Like if he wants to make it more specific, then the answer would be given as anterior septal myocardial infarction, where you can see that classical tombstone pattern, where you can see the classical tombstone pattern, and this tombstone pattern is the one that is also called as Pardee sign. The word is tombstone, or the alternative name for this tombstone is Pardee sign, P-A-R-D-E-E, tombstone or Pardee sign, present in V1 to V3. So I'll base my answer going more in favor of like anteroseptal myocardial infarction. Very good, Dr. Anupriya. That is Pardee sign also. Now let us compare the next ECG. This is especially for if you are an FMG student and you're listening to this, because I don't know what fascination the FMG examiner has with asking this ECG of MI, where okay, I'll not say, otherwise it will become more obvious. Yes, guys, can I comment? Can I expect some answers here? Especially if you're an FMG, everybody can comment, but those, if you are an FMG student listening to this, बहुत बार आया हुआ. Yes. लीड नंबर 2, लीड नंबर 3 और लीड नंबर AVF में क्लासिकल ST सेगमेंट एलिवेशन प्रेजेंट है विद अ कॉन्वेक्सिटी. मुझे नहीं पता क्या फैसिनेशन है गाइस, बट वो हर बार इसमें ना 2-3 AVF में चेंजेस आ रहे हैं. सो वेरी गुड गाइस, आई हैड वेरी गुड इनपुट फ्रॉम लॉट ऑफ यू. I mean, obviously in the chat I can't pick up that which exam are you preparing for, but then inferior wall MI is again something that they love to ask. So I've described 3 before you: posterior wall MI, then is gonna be inferior wall, then is the anterior wall myocardial infarction. This is gonna be the involvement of the right coronary artery, and the leads which will be involved in this case would be lead number 2, lead number 3, and lead number AVF. And you can also notice that in this particular case, the heart rate of this patient will begin to slow down. Here it's around 75, but gradually because of the vagus activation. Yeah, Karthik, you were right. IV fluids can be given if there is hypotension. If he mentions like inferior wall MI case, and he mentions there is hypotension, so this is the only type of MI where IV fluids can be given to the patient, though this is playing with fire. You know that 500 ml bolus that you're giving is playing with fire because you're trying to utilize the Frank-Starling law. But like that's the only option that you have, that the remaining part of the heart, whatever is normal, you're trying to increase the cardiac output by stretching the muscles. Frank-Starling law होता है stretch the heart and the cardiac contractility will increase, because MI will cause damage to small part of the heart. So the remaining part of the right ventricle is normal, so you can stretch it and make it work more, though it's like beating a tired horse. That's why I say playing with fire when you give IV fluids to this patient, but that's what we doctors do, playing with fire all the time. Right? Those emergency scenarios that we handle on a regular basis, they can go south immediately in a moment. The moment it goes up and everything is BP goes up, everybody is happy. You know, when it falls further, that's when everybody is saying, no, you must have done something wrong. So that's like hypertrophic cardiomyopathy में IV fluid क्यों देंगे बच्चे? मतलब why would we give IV fluids to hypertrophic cardiomyopathy? That doesn't make sense, right? We can give IV fluids if he's having diarrhea, dehydration, not a problem. Okay, so these were like the questions that have come up. Okay, quick inputs here with respect to the treatment for myocardial infarction: presence with bradycardia and vomiting. The best known is a mnemonic that is used for treatment of myocardial infarction. Whatever be the type of MI, ST versus non-ST elevation MI, best known is the treatment that is required. Can you tell me the window period for thrombolysis, window period for fibrinolysis in ST elevation MI? And we can move on. Options are standard: 3 hours, 6 hours, 9 hours, 12 hours. Quick answers here: window period for fibrinolysis in inferior wall MI, in any type of MI. ST elevation MI. Yes. Window period would be answered as 12 hours. Window period would be answered as 12 hours. In this 12 hours, whenever the person will come to the hospital, we will start thrombolysis within how much time of arrival? Then the answer is 30 minutes. Do take care of the fact that don't mix it with 90 minutes and all those things that people were saying. Window period for fibrinolysis for a patient of ST elevation MI should be kept as 12 hours. And within these 12 hours, if the patient will come within 30 minutes, I mean, whenever patient will come within 30 minutes, we have to start the treatment. For a case of ST elevation MI, if he himself mentions that the cath lab facility is available, then obviously thrombolysis will not be the main strategy that I'll be using. Then it is primary percutaneous coronary intervention that I'll be using for the patient. This is like a summary of the core aspects that we need to remember for ST elevation MI. If I don't have a cath lab facility, we will be going ahead with medicines. If it is gonna be cath lab facility, then it is primary percutaneous coronary intervention. Let me write down the drugs also. B would be for beta blockers. Most of the time that would be used as metoprolol. Alphabet E is for enoxaparin. That would be low molecular weight heparin, because I want to prevent the clot from propagating further. S is for statins, T is for thrombolysis, but this is valid for only ST elevation MI. So I'm just putting asterisks here to say thrombolysis is contraindicated in, let me write it also. Thrombolysis is contraindicated in a case of non-ST elevation MI. Reasons I have explained: non-ST elevation MI, the clot would be platelet rich, and here it is fibrin rich clot. So we don't give thrombolysis in non-ST elevation MI क्योंकि वहाँ पर platelet rich clot होता है. So it is best more mnemonic that would be used. Then M would be for morphine, O is for oxygen, A is for aspirin, and here with aspirin we give a second medicine, that is ticagrelor. Loading dose of what, bache? Aspirin and ticagrelor. So those are DAPT that would be given, and then we will be giving nitrates to the patient. Nitrates are contraindicated if on admission the systolic BP is less than 90 millimeters of mercury. Yes, so it is dual antiplatelet therapy that would be used for this patient. This is all strategy that would be used for those cases of ST elevation MI. In non-ST elevation MI, we'll be using intravenous antiplatelet drugs. Quick comments in the chat box. Which antiplatelet drugs are used in non-ST elevation MI to destroy the clot? Yeah, right. Which yeah, we can use, and there's so many drugs, no? Tenecteplase, Riteplase, Elteplase, any of those drugs can be used for management. Yes. The drugs that we can be using in this case are like eptifibatide. Yes. Or instead of eptifibatide, we can be using cangrelor in the patient. In non-ST elevation MI, it is still best known. Beta blocker, enoxaparin, statin, thrombolysis की जगह पे it is tirofiban, tirofiban that would be used. We don't use thrombolysis in this patient, guys. It is tirofiban. Any of the three drugs can be used in this patient, and subsequently the person would be taken up for percutaneous coronary intervention. So PCI is now done for both varieties, that is for ST elevation MI as well as for non-ST elevation myocardial infarction. The treatment of choice for myocardial infarction, whether he says ST elevation MI, whether he says non-ST elevation MI, in both the scenarios, guys, if he says what is the treatment of choice, your answer would be given as percutaneous coronary intervention is given in both of them. A word of caution: thrombolysis done only in ST elevation MI if I don't have a PCI facility, but the T in the mnemonic for non-ST elevation MI is for tirofiban, though I could be using cangrelor and eptifibatide because it was fitting in the mnemonic that is I have mentioned. So in half a page I've summarized the treatment for myocardial infarction, because your data has to be crystal clear in your mind, right? I said you are building yourself for the final, so all your data has to be concise. Whenever you are reading, my suggestion to you guys is summarize your data, make it concise. Every page of your notes should be having a stick-on pad. On that stick-on pad you should note down chota details, so that you are able to, because in the last time, you will not be able to yes, rescue PCI would be done within 90 minutes. Dr. Karthik, a very good question. I think it was FMGE exam question. Rescue percutaneous coronary intervention is done in case of failure of thrombolysis within 90 minutes. Like I have given medicine to the patient. Suppose I am in a small city in India, 50 kilometer or maybe 100 kilometer from Gurgaon, right, or Delhi. I did thrombolysis, but the medicine has been given, but ST elevation is not coming down. If ST elevation is not coming down, then I will have to transfer the patient to Delhi in an equipped ambulance. And the strategy where we are like after thrombolysis, we are saying ST elevation is not coming down. So within 90 minutes, we have to do this call of transferring him to a higher center, that is rescue PCI, though there can be a lot of medical legal issues there, because relatives will say like this, oh, why did you not send earlier? So you must always take an informed consent before you are doing thrombolysis in a patient, because lots of time, you ideally should say take him to a bigger center if you want, where they do a cath lab procedure. Now they say no, we can't go because it is like traffic jam on the highway or some whatever be the reason. I mean, you should be explaining the concepts to the patient properly. And rescue percutaneous coronary intervention, the cutoff here is again within 90 minutes of like the failure of thrombolysis, we should be going in for a rescue percutaneous coronary intervention. This was a question that was asked in FMG exam. Okay, so next we'll do a question with respect to nervous system. This was like the cardiac issues that we'll discuss. So bear with me for another hour or so, I think, and you guys would be more fighting fit. Let's do Deepak, can you when to answer question? Deepak, I could not get your question. Okay, 90 minutes and 30 minutes. Okay, I'll explain it, Ravi. Meanwhile, you guys can take a break. Those guys who are tired can take a break. There are two concepts, guys. One is balloon angioplasty. Balloon angioplasty is door to balloon time. Like patient or myocardial infarction, when he comes to me in the first 24 hours, and I am working in a cath lab equipped hospital, then I should be starting, like patient came now. How much is the time? 2:17. So within 1.5 hours, I should do a balloon angioplasty and I should destroy the clot. This is technically called as primary percutaneous coronary intervention, right? But if a patient is coming to a hospital where I don't have facility for PCI, I'll say them, take him to bigger hospital. They say, no, it's so far away. How do we take him? What if he collapses? I'll say, we'll give you ambulance. We'll give you doctor in the ambulance and he can be transported. Baki, it's your wish. You want to keep him here. They say, no, sir, we trust you. So I said, okay, fine. We start with thrombolysis. This can be done within 30 minutes of arrival of the patient. This is all within arrival of the patient to the hospital, because in the hospital slip, there's a punch in time. Na? The computerized slip will say patient admitted at 2:17 p.m. So within 30 minutes, we should start thrombolysis in the patient. ECG, basic treatment, best moon should be given, and then thrombolysis should be started within 30 minutes of arrival. But the second point is, patient had MI at 8 a.m. in the morning. So till how much time can you do thrombolysis? It is 8 p.m. in the evening. From 8 a.m. to 8 p.m. in between that time, whenever he comes, like he came at 2:17, so by 2:47, I will be starting thrombolysis. If he came at 5 in the evening, I'll do by 5:30. If I'm working in a bigger hospital where cath lab facility is available, patient came at 5. Heart attack occurred at morning, then by 90 minutes, that is by 6:30, I'll do the procedure. So this is what I wanted to explain for 90 minutes, 30 minutes and 12 hours. So window period is calculated from symptom, bhai. Window period is calculated from symptom, whereas the door time is from the arrival into the hospital. So this is like some baseline information that I mentioned. Now I think a couple of guys were requesting for a break, but actual exam is like long now. Like we started at 12 and it's only 2 hours, whereas the exam is gonna go for like 2.5 hours to 3.5 hours. And in fact, you will be making an entry much more earlier. Yes, Deepak, that is okay. Transfer time, we take 120 minutes. I'll just modify, Deepak, what you said in rescue PCI. In rescue PCI, no, Deepak, it is not like this. It is not like this. There are two separate strategies that are being used. One is the transport time, right? If the transport time is more than 2 hours, then we don't do any transfer of the patient. We straight away are gonna do a thrombolysis in a patient, right? And if it is transfer time is less than 120 minutes, then we take him to cath lab. That's a separate algorithm for if you're working in a non-cath lab hospital. But suppose in a non-cath lab hospital, there is no improvement occurring within 90 minutes. You have to anyway shift to a cath lab equipped hospital. That decision making will be 90 minutes. So yes, I think your point is seen. Transfer time and 90 minutes. Okay, fine, Deepak, your point is taken. Okay, we are having a 20-year-old boy with skeletal muscle weakness and grip myotonia. He's having a chloride channel defect, and which of the following is correct about this case? Guys, this is not cystic fibrosis. Come on, guys. I know you're tired, but that does not mean the topic is neurology, right? And this is not cystic fibrosis. Skeletal muscle weakness is not a feature of skeletal muscle weakness is not a feature of cystic fibrosis, and it does not have a grip myotonia. You know what is grip myotonia? You will like hold the finger, like you ask the patient to grab your finger. So he can grab your finger, he can't let it go. Like you grab it, you let it go. Here he'll grab it and keep it grabbed. उसको बोला ये finger पकड़ ले, वो छोड़ेगा ही नहीं. ऐसे पकड़ लिया आपका finger, right? So that is like grip myotonia. That is a slow relaxation of muscles. So this, guys, is a question that is trying to test your nerves. This is not cystic fibrosis. Cystic fibrosis will present with recurrent pneumonia episodes. Along with this, there would be presence of malabsorption syndrome. There is no mention of any recurrent pneumonia or malabsorption syndrome. Becker's muscular dystrophy and skeletal muscle dystrophy, Becker's muscular and Duchenne's muscular dystrophy do not have grip myotonia, and both of them are having a defect in dystrophin gene. So some questions in the paper will be solved by exclusion. Not all questions are gonna be a lollipop. This is an example of the same. The correct answer for this, as now most guys are realizing, would be given as option number B. That is called as Becker's disease. Becker's disease is a channelopathy. Becker's disease is a channelopathy. If you listen to the NEET PG segment, I've discussed channelopathies, hypokalemic periodic paralysis, hyperkalemic periodic paralysis. I've described Anderson-Tawil syndrome, all those things, right? So that is where I've said this statement: chloride channel defect in the skeletal muscle and having a grip myotonia. This is Becker's disease. So this question is like based on exclusion capability, guys. Not every question is gonna be like a lollipop, right? So I had to make it like, not every MCQ will be subarachnoid hemorrhage, right? So let's attempt now the second one. Channelopathy is okay, doctor. We'll try to do that. Channelopathies. Otherwise, like if you listen to rapid revision, doctor, that would be a much more better way to give justice to the topic, because here I'll just give you maybe a mnemonic or a hack that would not be sufficient for that topic. It's only 20 minutes, doc. You listen at 1.5x, it will take you 10 minutes of your time, sir. That I am saying, and you will get a better understanding. Believe me. If you move on to the channelopathies topic, 10 मिनट दे दो मुझे और उसका कॉन्सेप्ट सिर्फ सुन लोगे ना एक बार, आप सिर्फ वो डीपोलराइजेशन रिपोलराइजेशन में समझाया, it will make it easier for you. Here I'll give you shortcut and a mnemonic that shortcuts do not work in an MCQ. So I think that more justice to the topic. Okay, fine. Star of death. Blood in the basal cisterns. This would be subarachnoid hemorrhage. The case scenario in this particular case would be 25-year-old lady presenting with severe headache. Doc, I have to address most of them. 25-year-old lady presents with severe headache and multiple vomiting episodes, and the headache started after missing a breakfast. So in the first two lines of the question, initially you will think that this is migraine, because migraine attacks can also, and vomiting episodes can be starting after missing the breakfast. But then the key word in the question is present to do nuchal rigidity, and that would be like, when you say the word nuchal rigidity in a question, nuchal rigidity tells you either it will be meningitis or it's gonna be subarachnoid hemorrhage in a patient. Even if they don't give you the CT scan in this case, your answer would be given as subarachnoid hemorrhage on the basis of the combination of headache with nuchal rigidity. If it was, there's no fever in this case, so I can't say meningitis. This is not migraine because there is no nuchal rigidity. Intracranial space occupying lesion will be having a long history. And tension headache is always a diagnosis of exclusion. I mean, you straight away cannot diagnose it as tension headache. It is always a diagnosis of exclusion. So this would be answered as subarachnoid hemorrhage, the worst headache of her life. The most common location of berry aneurysm is anterior communicating artery. But if he says what is the most common location prone to rupture, if he changes the question to what is the most common site that is prone to rupture, then it is going to be posterior communicating artery. So there are two separate MCQs, and the most common cranial nerve which will be involved in both a ruptured as well as an unruptured berry aneurysm is third nerve palsy. It is going to contribute to development of ptosis in this patient. Yes, top of the basilar artery. Yes, Dr. Shreya, you perfectly right. The investigational choice for subarachnoid hemorrhage in this patient would be answered as a non-contrast CT scan. There would be two findings that would be given. One would be a down and out also. There would be one presence of blood in the sylvian fissure. And the second feature that can be given is the star of death. Then they've asked what is the next best investigation for this condition. You can comment in the chat box here. Sixth nerve will involve due to raise ICP, but overall the most, because usually the PCOM one will be adjacent to the third nerve only. So sixth nerve will involve if there is development of raise ICP. Okay, we will be doing CT angiography. Okay, before that, better answer than CT angiography. Before CT angiography, what is a better? Okay, very good. Invasive cerebral angiography. Guys, I need to anyway put a endovascular coiling procedure in the patient. I have to put in I have to ensure the fact that there is the platinum coil deployed inside the berry so that it can prevent a re-rupture. It can prevent development of re-bleeding in this patient. So on a comparison, if I have to select between CT angiography and invasive cerebral angiography, my first answer would be given as invasive cerebral angiography. Normally, I always talk about non-invasive investigation to be done, but in this question, I am talking about an invasive investigation to be done because I need to, in this particular case, fix the problem by going in for in the same setting only. When the patient will be taken in the cath lab, we can take a femoral access, go up into the descending aorta, go up to arch of aorta, carotid artery, from carotid artery into the brain blood vessel, that is wherever the berry is located. So it is endovascular coiling which can be done in the same setting for treatment of choice. So invasive cerebral angiography will be a better answer over CT angiography in this particular case. Whenever the berry will burst, the feeder vessel of that will tend to undergo spasm. Like this berry had actually popped off. So what will happen is that the feeder vessel related to this will exhibit a protective vasospasm, and that will cause a cerebral ischemia, and that is it. The drug of choice for this patient that would be done. Coiling, doctor, not clipping, not clipping. It is coiling that would be answered. The drug of choice for this patient would be answered as nimodipine. The drug of choice for this condition to prevent the vasospasm from occurring. Yes, a very good answer. Should you give antihypertensive drugs to this patient? Then, Dr. Sangeeta, my point is if I give antihypertensive drugs, I will worsen the brain perfusion. Let me just highlight that formula before you. Cerebral perfusion pressure is a difference of mean arterial pressure minus the intracranial pressure. So I think in the question, the BP was given to be like 160. That is good. 160 is a good value because if ICP will raise the raised systolic BP is a compensatory mechanism that is maintaining the peripheral perfusion of this patient. So even if the BP of this patient is elevated, I will not lower it. Obviously, if the BP is more than 220 by 130, I will be lowering the blood pressure of this patient. But otherwise, in cases of raised ICP, I can call it word like permissive hypertension. That increased mean arterial pressure will counterbalance the raised ICP of the patient and will maintain the brain perfusion of a patient. So lowering of blood pressure of this patient would not be advised unless and until the patient has gone into hypertensive crisis. And majority of the cases where you have a very aneurysm rupture, it is because of the inherent weakness in the brain blood vessel. This lady is not hypertensive. She is only 25 years of age. She is non-hypertensive. Her BP is elevated because of the compensatory Cushing's reflex operating in this case. I repeat my statement. This is a 25-year-old lady. The reason why her BP is elevated is primarily because of a compensatory Cushing's reflex mechanism that is operating, and that is what is called as permissive hypertension in this patient. So nicardipine will be used in this patient if BP is elevated, but otherwise a more specific drug, nimodipine, will be used to prevent this vasospasm from occurring, to prevent the worsening of the brain ischemia. And if it says what is the most common cause of death in subarachnoid hemorrhage, you guys can comment in the chat box. Leading cause of death in this patient. Yes, guys. The leading cause of death in this patient having blood in the basal cisterns, the star of death, the worst headache of my life, thunderclap headache. Waiting for your answers. Yes, guys, without any. Okay, vasogenic cerebral edema. Very good. Cerebral infarction. That is one. Okay. Yes. A more technical answer would be DCI. The most common cause of death is vasospasm. And to make it sound sophisticated in the MCQ, it is spasm only, na? That is spasm only. That spasm peaks by about 48 hours after the acute event of subarachnoid hemorrhage. The spasm worsens after 48 hours of the acute event. So therefore, these patients can have a late neurological deterioration. There's a possibility that when she came, her GCS was 10 on 15 or maybe 12 on 15, but after 48 hours, her GCS will become less. Her relatives will fight with you and argue with you. Oh, our patient is deteriorated under your care. You will try to explain to them that why the patient is deteriorating is because of the fact that there is a vasospasm, protective vasospasm occurring because the brain is trying to prevent the chances of rebleeding. Nowadays, these chances have become lesser because we do immediately coiling. And if I will do coiling in this case like this, then the chances of this vasospasm and all these things will become relatively lesser. But still, overall, like, lots of time these facilities may not be available, then it is delayed cerebral ischemia that would be required. There are two procedures that you can be doing in this patient. As you can see, one procedure we can be doing in this patient is clipping. The second procedure that you can be doing in this patient is the coiling part. In the textbook, first coiling part is given and then the clipping part is given. So the coiling part, because of faster intervention. No, for clipping I'll have to send to neurosurgery department. They have to take a transfer, then they'll do a craniotomy, then they'll do a clipping in a patient. And interventional neuroradiology is gradually replacing the neurosurgery domain. No, so that is why DCI, delayed cerebral ischemia, that is a more sophisticated word for vasospasm that is present for thunderclap headache, which is a presentation for this condition. What do you mean by thunderclap headache? I mean headache increasing in how much duration? Like suppose I'm talking to you and suddenly I hold my head and I say, oh, I can't take this Skype session again. If headache worsens within 5 minutes, like 5 minutes ago, I was okay. But if within 5 minutes, my headache becomes so severe that I just hold my head and I say, oh, sorry, doctor, I can't take it. I don't know what is going on. I'm having the worst headache of my life. That is what you mean by the word thunderclap headache. So it is like, yeah, it's a range actually 60 seconds to 5 minutes. It starts within 1 minute, peaks like, I'm talking to you, suddenly I hold my head. And then like I stop talking to you. And after 5 minutes, you are asking me, what happened? What happened? And you are saying, "Ay, yaar, baat mat karo, yaar, mujhse baat nahi ho raha hai." Right? Like that. I'm like, no, man, just don't ask me anything. Just take me to the hospital, like something like that. Right? So it starts within 1 minute, peaks by 5 minutes. That is like the thunderclap headache. Sangeeta, nicardipine is to be answered for hypertensive crisis. Like if I say patient is having hypertensive crisis, the definition of crisis is with target organ damage, like hemorrhagic stroke, ischemic stroke. In hemorrhagic stroke and ischemic stroke, the cutoffs are different. For hemorrhagic, 220 by 130 is when we intervene. At ischemic stroke, it is 185 by 110 that I'll discuss in my subsequent slides. Nicardipine is for hypertensive crisis, and in subrecurrent hemorrhage, it is nimodipine to be answered. I hope that solves the query. Okay, moving to the next question. This lady fell in the bathroom and she had a lucid interval. I mean, she developed unconsciousness, then she became conscious, and consciousness between two periods of unconsciousness, in a sense that this lady is now becoming forgetful, drowsy, and now not waking up after 7 days. The non-contrast CT head is given in this case. The answer in this case would be given as, yes, answer would be given as acute subdural hemorrhage on the right hand side in this case. You can notice this is left and this is right, and you can notice the concavo-convex bleed which is present in this case. This would be an acute subdural hemorrhage in this patient. Let us compare this with the next image. Same question, but in this particular case, you are noticing that the area has become black. The area has become black. So the answer in this patient would be given as chronic subdural hemorrhage. Tell me the treatment or choice for chronic subdural hemorrhage. The area is appearing black, so we're calling it chronic subdural hemorrhage. Yeah, bridging vein rupture. Tell me the treatment or choice for chronic subdural hemorrhage. You want me to give option? Craniotomy, burr surgery, between the two. Yes. For chronic subdural hemorrhage, they've asked what will be the treatment that would be done. Your answer would be given as burr surgery would be done in this case for chronic subdural hemorrhage. In acute subdural hemorrhage, we might require a craniotomy in a patient depending on the intracranial hemorrhage score in a patient. And then is the standard question. Yes, very good, very good. A 25-year-old guy had a road traffic accident. His GCS is low. The non-contrast CT head is shown. I'll zoom into the CT head. You can see these punctuate bleeds. You can see these punctuate bleeds at the junction of the gray matter and the white matter. Yes. Okay. Options are traumatic axonal injury, diffuse axonal injury, cerebral contusion, extradural hemorrhage. Select between one. Traumatic axonal injury, diffuse axonal injury, contusion, and extradural hemorrhage. Yes. The correct answer is diffuse axonal injury if you are able to see 4 or more than 4 punctuate bleeds. If you are able to see 4 or more than 4 punctuate bleeds at the junction of the gray matter and the white matter, that's important. The bleeds are present at the gray and the white matter interface. Then you are going to be saying that this is diffuse axonal injury. There's a possibility that the CT scan in this patient can be normal also, because if the bleeds are going to be very, very small in size, then your answer would be given as traumatic axonal injury. Any patient with road traffic accident who would be having, yes, normal CT, that is what I'm trying to say. If the patient is having a normal CT scan, then we'll call it a traumatic axonal injury. If we can see the bleeds, then it is going to be called as a diffuse axonal injury. If the bleeds are very small, the CT will be normal, which is why he will also ask you the investigation choice for traumatic axonal injury. You can tell me what type of MRI will be done here. Investigation choice for traumatic axonal injury. Okay, diffusion weighted MRI, yes, susceptibility weighted MRI, SW-MRI. It would be SW-MRI. Investigation choice for traumatic axonal injury would be answered as susceptibility weighted MRI. There are two possibilities in a question. One can be CT scan can be normal, or they can be visible bleeds also present. Depending on the situation, the answer would be given, and the guy would be having a progressive deterioration, and it is conservative management that would be done in this case. Next is the case of extradural hemorrhage, where you can see that bleed present. Very, very classical. Diagnosis is anyway mentioned. Can you tell me the treatment or choice?
Okay, options in this case are burr hole, then is a craniotomy. Yes, waiting for answers. Craniotomy with ligation of the bleeder. In emergency scenario, we can do a burr hole in this case, but the treatment of choice in this patient would be answered as craniotomy with ligation of the bleeder. It would be a decompressive hemicraniectomy that would be done along with ligation of the bleeder would be done for management of this patient of EDH, which is a very straightforward scenario where the bleed would be occurring from the middle meningeal artery. Okay, very good, very good. Moving to the next one, a 55-year-old lady with hypertension develops a sudden onset face and arm and leg weakness for past 3 hours. This is a pure motor stroke that I'm describing. In pure motor stroke, usually the area that is involved is also beginning with P. That is gonna be a posterior limb of the internal capsule that would be involved. Yes, guys, the diagnosis in this condition would be given by you as intracerebral hemorrhage. The case scenario that is given to you is of ICH. It is a intracerebral hemorrhage in this particular case. It is in this patient that the BP of this patient would be elevated. The person would have gone into hypertensive crisis. In hypertensive crisis, the BP can be as high as 220 by 120 millimeter of mercury. Along with this, target organ damage would be present. There can be two questions that can be asked to you. What is the target BP to be attained? Can you have quick comments in the chat box? What is gonna be, yeah, the leading cause of this is hypertensive crisis. What is the target BP to be attained? The drug that will be used, I think somebody asked me where will we use nicardipine. This is where we are using nicardipine in the patient. Yes, the target BP in this patient would be less than 140 by 90. This has been asked in INI-CET as well as in the FMGE exam. The target BP in patient who's having an intracerebral hemorrhage should be kept at less than 140 by 90. The drug that will be used in this patient would be nicardipine so that I am able to control the blood pressure of this patient. And this was a pure motor stroke where the posterior limb of the internal capsule that would be damaged. Usually what is the blood vessel that will be damaged here are the small blood vessels. If he says what is the blood vessel, no sir, it is not first hour, it is 24 hours. It is first 24 hours. It's not first hour. It is the penetrating branches. It is the penetrating branches. No, Deepak, you're right. Lenticulostriate ki branches will be affected. So it is penetrating branches of the lenticulostriate artery. I want to bring to your attention, it is not the artery that will burst, it is the chota branches of the artery that will burst. So it is the chota penetrating branches of the lenticulostriate artery that would be bursting in this case. And the most common site for this would be like the putamen. The usual blood vessel that is affected in this patient is the middle cerebral artery circulation. So hypertensive crisis, it is mainly gonna be like the trigger for development of this scenario of intraventricular, intracerebral hemorrhage in a patient. Along with this, there can be some extension into the brain also, so intraventricular can occur, but this bleed that has been shown is the typical intraparenchymal bleeding or intracerebral hemorrhage that is occurring in this patient. Absolutely, it's not the middle cerebral artery as I'm clarifying, it is the chota branches. अब देखो ना ये आगे divide कर रहा है ना M1 segment of middle cerebral artery से lenticulostriate artery, फिर lenticulostriate artery का भी जो छोटा छोटा branches होता है, they are the ones which would be affected. Okay, so I had a good interesting question coming up here. किसी ने mention भी किया there is a possibility that he can mention atrial fibrillation patient is having warfarin toxicity and that is causing a brain hemorrhage in a person. So what is the antidote for warfarin toxicity causing a brain hemorrhage? Yes, it is same as hemorrhagic stroke, doctor. It is same as hemorrhagic stroke. I mean, hemorrhagic stroke is a term that I'll be using for like to मतलब explain to a non-medical person कि भाई hemorrhage से समझ में आ जाता है ना कि bleeding हो रहा है. But the technical word is the site of bleeding that would be intracerebral hemorrhage. But your point is spot on. I mean, hemorrhagic stroke को ही हम intracerebral hemorrhage बोलते हैं. MCQ में इतना easy भी नहीं करेगा ना आपको. Hemorrhagic stroke नहीं लेगा तो इसलिए intracerebral word याद रखिएगा. Okay, yes. It is warfarin toxicity with brain hemorrhage. What we will be giving is a prothrombin complex concentrate, and along with this, we'll be giving is vitamin K to the patient, but will not be giving fresh frozen plasma. It is prothrombin complex concentrate. Then for apixaban toxicity with the intracranial hemorrhage, the antidote that you will be giving is Yes, thank you, Dr. Ruzma. Quick comments, apixaban toxicity? Yes, and Dixon at alpha. So lots of time, like he might trying to mix it up, the data that he's giving you, he can be mixing it up with a bit of pharmacology. And the next one I'm saying verbally only, like idarosizumab, that's used for dabigatran based toxicity. So I mean, they can test your pharmacology there, and you guys are anyway aware of that. Okay, fine. Moving ahead. Okay. Yes, ischemic is yes. Doctor, in ischemic stroke, no, he will usually ask you regarding the cutoff for starting thrombolysis. That is 185 by like. Okay, I'll just write it because AIS will come up subsequently. You see, AIS, you have to use tenecteplase. You are now aware that tenecteplase is FDA approved now, or we can be using L-teplase. The usage of this is contraindicated if the BP is more than 185 by 110 millimeter of mercury. So my immediate goal in ischemic stroke question will be that I need to keep a BP less than this. I can get like 180 by 100, I can get like 170 by 100. In acute ischemic stroke, in immediate basis, what you're supposed to do is ensure that your BP is less than this particular value. In hemorrhagic stroke, earlier there was a lot of concern regarding lowering of BP because they said it will worsen the brain infarction. But now he says if you don't lower the BP, there will be rebleeding. So now they decided, okay, decrease it over next 24 hours to less than 140 the target. But in AIS, we keep it to like, because of the risk of rebleeding in hemorrhagic stroke, less than 140. Here it is 185 that I would like to obtain. Okay. This patient is having pyogenic meningitis. How do I know pyogenic? Because there are neutrophils present with low sugar, and the empirical treatment for pyogenic meningitis is always ceftriaxone with vancomycin. The correct answer for this, no, it will not be ampicillin, because if it was like an alcoholic patient, or if the question was mentioning regarding a child, here like there is no age group given, so we'll take it to be an adult patient, and the standard treatment for pyogenic meningitis is ceftriaxone with vancomycin, and ampicillin is only to be asked for listeria cytogenes. And in which age group listeria is present? Then listeria is common in neonates. It is present after 55 years of age. It is common in those patients where the immunity is less, or he mentions alcoholic. In all MCQs of pyogenic meningitis, if it is neonate, age more than 55, cell-mediated immunity is lesser, or alcoholic, then it is listeria. That is when ampicillin comes in. Otherwise, like for standard treatment, it is mainly going to be answered as ceftriaxone plus vancomycin. The next question is also very simple and is a repeat one: lymphocytic pleocytosis with case of cryptococcal meningitis. In cryptococcal meningitis, one that you have to give, treatment at the moment, and then you have to start antiretroviral therapy. This antiretroviral therapy is to be started subsequently after like the CD4 count of this patient has tend to increase. The CD4 count of the patient should be more than 100. Like you have to give prophylaxis in this patient, and subsequently when the CD4 count is more than 100 for at least more than 150 for more than 3 months, that is when we can be starting antiretroviral therapy in this patient. Prior to that, it is prophylaxis that would be given for this patient. Yes, the main treatment for this patient would be liposomal amphotericin B plus flucytosine, and then later we give fluconazole. Guys, the answer is not C. I think this was an easy question. It is first liposomal amphotericin B, and then we give fluconazole for these patients, and later on antiretroviral therapy should be given for these patients only when the CD4 count of the patient is elevated. So first we have to treat this patient, and then subsequently, why don't we? Because they don't cross the blood-brain barrier, doctor. Aminoglycosides have limited penetration into the blood-brain barrier, so that is why we give ceftriaxone, which has a third generation cephalosporins. They have a good penetration into the blood-brain barrier. If the CD count is less, then we'll have to, only later after it is more than like this particular value, then we will have to intervene. Okay, quick inputs here with respect to the flow chart. Okay, Pankaj, I think I have again addressed that in my rapid revision. I'll try to do this in this video also. Okay, drug of choice is not fluconazole, man. Drug of choice is not fluconazole. It is liposomal amphotericin B with 5-flucytosine, and then for prevention subsequently, this is given for 2 weeks. And then subsequently for 8 weeks, we'll be giving. And anyway, like because they ask about it, no, if patient is having TB and you have to start antiretroviral therapy subsequently, like TB with AIDS, then in patient of tuberculosis with HIV, first ATT is anyway to be given, and after 2 weeks it is antiretroviral therapy to be given. But if he mentions the word HIV with tubercular meningitis, then we will have to start antiretroviral therapy after a gap of 4 to 8 weeks. Yes, the reverse can happen. Reverse can happen if it is tubercular meningitis given in a question. If it is tubercular meningitis given, in those circumstances, the answer for starting the antiretroviral therapy would be delayed in a patient. If the reversal is done, then it is obviously the risk of iris, which has been asked multiple times, immune reconstitution, inflammatory syndrome. Yes, upper limit of 8 weeks. Upper limit. We have to answer. If suppose 4 weeks is also given and 8 weeks is also given, then we will answer it at 8 weeks because I don't want to take a chance ना भाई अगर मैंने जल्दी स्टार्ट कर दिया और उसके वर्सनिंग का symptoms होते हैं tubercular meningitis के and anyway TB meningitis is slow to respond to treatment also. So if at least 4 weeks also given and 8 weeks also given, then mark it as 8 weeks per se. That is primarily to minimize the chances of iris in a patient. The final summary is decrease the risk of immune reconstitution, inflammatory syndrome. Okay, as far as findings of meningitis are concerned in a patient, normal cells would be anywhere between 0 to 4, 0 to 5 cells. Sugar would be 2/3 of the whatever is the blood sugar, and the proteins would be in a range of 15 to 45 milligram percent. The opening pressure will be between 50 to 180 centimeters of water. And if it is acute bacterial meningitis, then I'm going to be having neutrophils, which are usually going to be like thousands to 10,000 neutrophils present. The blood sugar in this patient will be less, that is less than 0.6. Proteins will be elevated, opening pressure would be elevated, and the color of the CSF will be usually turbid. Never use color for diagnosis. Turbid or cloudy, it does not matter. It is never useful for diagnosis. It is mainly the cells that would be used for polymorphonuclear cells. But in tubercular meningitis, you will mainly be having like mainly lymphocytes present. It is like lymphocytic pleocytosis that would be seen in this case. Or he might give values also, like he may say 80% lymphocytes, 20% polymorphonuclear cells, whereas the situation would be reversed for the superior diagram. In this particular case also, sugar will be less, but the only time the CSF sugar can be zero, only time the CSF sugar can be zero can be acute bacterial meningitis, that is hypoglycorrhea. Hypoglycorrhea. So CSF sugar can be zero. CSF sugar can be zero only in patients of acute viral meningitis. The proteins in this case would be elevated anyway. They would be super elevated, so they can form a clot in the test tube. That's what we call as a cobweb coagulum. The opening pressure would be elevated, and the color in this particular case can either be straw or you can mention cloudy. As I've explained, color is never to be useful for diagnosis of acute bacterial versus tubercular meningitis. In viral meningitis also, we can be having 100 lymphocytes present, but in this particular case, what you will notice is very characteristically that it is the sugar in the CSF that would be normal, but the proteins in this case would be elevated. The history would be short in this case, and the color of the CSF in this particular case can be clear, or it can still be like turbid in some cases. It can be clear, it can be turbid. Like I said, color is never to be used for diagnosis. So in viral meningitis, it will always be a short history. In tubercular meningitis, it will usually be a malnourished individual. Usually you'll talk about a malnourished child, and there would be a long-standing history given. Usually like the history will be over weeks or maybe over months as well. But in meningitis, the history will be always over a couple of days, never like going into weeks altogether. But if they give you a report in which everything is normal, and only the proteins are elevated, if they give you a report where everything is normal, and only the proteins are elevated, then it would be Guillain-Barré syndrome, about which I'll talk about in the later part of the discussion, where intravenous immunoglobulins would be used. Guillain-Barré syndrome is usually asked with respect to the following situations. Either it is going to be like it happened in Pune, it can be Campylobacter jejuni as the risk factor, or it can be E. coli, or it can be hepatitis E virus, or like it happened in Maharashtra, that is Zika virus previously. So Gujarat, sorry, Zika virus, Campylobacter jejuni E. coli, hepatitis E virus, or Zika virus are the triggers for development of Guillain-Barré syndrome, where we use Brighton criteria for diagnosis, and the discussion of that Brighton criteria would be like taken up subsequently. Then is subrecurrent hemorrhage. In subrecurrent hemorrhage, you will notice RBCs in the CSF. We don't have RBCs in the CSF in any other condition except for the condition that we're discussing at the moment. The pressure can be elevated, but yeah, bloody CSF can be written here. So as such, nowadays we don't do lumbar puncture for diagnosis of subrecurrent hemorrhage, but just for the sake of completion, in patients after 24 hours, you might be having a yellow tinge to the CSF, and this yellow tinge to the CSF is what is called as xanthochromic CSF. Though for this is only for academic reasons, because in subrecurrent hemorrhage it is straight away invasive cerebral angiography that should be done in the patient subsequently. Okay, then is those standard images. One, you can notice this cobweb coagulum, and you can notice the green, you can notice the bluish stain with the reddish bacteria. That is the red bacilli can be seen in the background. So I know that I'm dealing with a case of tubercular meningitis, where for management purposes, I'll be using antitubercular treatment for 1 year. And along with this, we'll be using steroids, that is Dexona or dexamethasone will be given for 6 weeks. The reason why we give steroids is to reduce the cerebral edema component. But if you look at the right image, you can notice, I can say turbid CSF, and then you can see in the gram stain. In the gram stain, you can see these blue dots. These blue dots are 2, right? In groups of 2. So this is a Diplococcus. This is a gram positive Diplococcus. So because it is a gram positive Diplococcus, I can mention this as the answer as pneumococcus. But suppose these images were reddish. If these images were not like, I can say like on a comparison mode, I don't have a appropriate color for gram stain for gram negative, so I'm using a red color. But if it was gram negative and it was a Diplococcus, then I would have thought in terms of Neisseria meningitis. So I don't have appropriate colors of the gram stain, so I'm just saying blue versus red. But what I'm trying to emphasize before you is that if it is gonna be bluish appearance, then it is pneumococcus. If it's gonna be reddish, it is Neisseria meningitis. Both are Diplococcus, and this would be a presentation with respect to pyogenic meningitis. The leading cause of this anyway is pneumococcus, but if he mentions a rash, if he mentions thrombocytopenia, he talks about petechiae, he talks about purpura, then in those circumstances, if petechiae and purpura are given in a question, Waterhouse friction is given, then again Neisseria meningitis is which is to be answered. Okay. Next is a question for you guys. Since you've been silent, some guys are commenting, but still, like this is the pelvic crest. This is the pelvic. This is the the pelvis of the patient. So what I'm doing is that I'm using the peak of the iliac crest. This is the iliac crest, and I'm drawing a line. I'm drawing a line so that I can reach L3, L4 space. Tell me the name of this line which is connecting the pelvic, which is connecting the iliac crest of the patient. I mean, you draw an imaginary line. Like I'll just do this activity once again. You can see that this is the pelvis of the patient. I'm talking about iliac crest. So iliac crest is the reference. Iliac crest is the reference. And then I'm drawing a line which is connecting and is bisecting L3, L4. So this line is the one that is called as Tuffier's line. This line that I'm mentioning at the moment before you is called as Tuffier's line. This Tuffier's line would help you identify L3, L4. The interspace between L3, L4, below this is L4, L5. So how to identify L3, L4 is the Tuffier's line, and that helps you basically determine the location. And then subsequently, like you can do lumbar puncture. The first needle that you can see here, you can comment in the chat box what is the name of the initial needle. Like this needle, which is having a cutting edge which is more sharp, right? This is called as Quincke's needle. And the second one that you can see, yes, would be called as Sprotte's needle. That would be a traumatic needle. Using these needles, I can be managing the post-lumbar puncture headache relatively. Please comment in the chat box, what is the drug of choice for post-lumbar puncture headache, post-dural puncture headache, PDPH. Drug of choice for management of post-dural puncture headache. Yes, IV caffeine. IV caffeine is the drug of choice for management of post-dural puncture headache. Very good, very good. Yeah, we'll do conservative, that's okay. But the drug of choice for this condition is caffeine basically, and that can be given intravenously, or it can be given orally also, orally in the form of hot drinks, etc. Though the last resort we can do in these patients is we can also give a blood patch where we will inject patient's own blood into the same intervertebral space so as to seal the tear in the dura mater of this patient. So low volume blood patch can also be used in this patient as a last resort, but the single best answer for this would be intravenous caffeine to be used. Then is that classical starry sky appearance that you can see, and you can also notice that rice grain calcification. This that you can see is the cysticercoid. This is the rice grain calcification that is present. You can see the starry sky appearance, multiple hypointense lesions with the eccentric white dot, that is the scolex. You can see the scolex in the periphery where the arrow is present. Yeah, this is not caused by eating pork. As you know, the main route of transmission of this would be fecal consumption. It is fecal consumption, fecal route of transmission. It is not pork that is responsible. It is fecal that is mainly route of transmission. And yes, cysticercosis cellulosa, the larva that will be hatching in this patient. Question in the paper said, how would you differentiate whether it is tuberculoma or whether it is neurocysticercosis lesions? So the test that can be done is magnetic resonance spectroscopy. If magnetic resonance spectroscopy shows a lipid peak, then it goes in favor of diagnosis as a tuberculoma, which is a differential diagnosis of neurocysticercosis. The investigation to be done is MR spectroscopy. If he says what is the first test to be done in a patient, the initial test to be done for identification of neurocysticercosis, then the initial test in neurocysticercosis, we will be having an amino acid peak, and in cases of tuberculoma, there would be a lipid peak present. The first test that we'll be doing in this patient is a CSF immunoblot for neurocysticercosis antigens. That's the initial test that would be done. If he says what is the imaging modality of choice for this condition, then our answer would be given as gadolinium enhanced MRI. Yes, amino acid peak in neurocysticercosis. You are right, Dr. Spot on. Then it is a gadolinium enhanced MRI that will be used. And imaging to differentiate from a tuberculoma is magnetic resonance spectroscopy. We'll do a fundus examination for subretinal cysticerci and to rule out papilledema component in this patient. In fact, biopsy is an absolute criteria for diagnosis of this condition. Biopsy, like if he says absolute criteria for diagnosis, then it is mainly a biopsy or it is fundus showing subretinal cysticerci. Like he can give you multiple correct options there. Biopsy is one, or fundus showing subretinal cysticerci are like absolute criteria for diagnosis of neurocysticercosis. They've also asked for management of this patient. Pehle kya denge? So we will not start with albendazole. We'll start dexamethasone in these patients to decrease the vasogenic cerebral edema. After about 40 to 72 hours, when the swelling in the brain will come down, that is when this patient will be started on albendazole. It is albendazole that is the subsequent drug that would be started for management of this patient. And subsequently, like antiepileptic drugs would be started in these patients also. That would be like sodium valproate, and antiepileptic drugs may be continued in these patients for minimum 2 years so that we can handle these patients relatively better. That's to prevent the recurrence of seizures in these patients also. Yes, and subsequently dexamethasone would be used. So great guys, neurocysticercosis was a good one. As far as acute ischemic stroke is concerned, I just want to bring to your attention that in acute ischemic stroke, you might be able to pick up this very classical finding. Please comment in the chat box. We have carbamazepine for focal seizures. Can you tell me the radiological finding that is shown before you at the moment? This one that I'm showing, that big clot that is present? Yes, dense MCA sign. This is the initial finding that would be seen with acute ischemic stroke. Then in the subsequent part, what you will get is loss of gray matter and white matter differentiation. Like the gray and the white matter can be seen on a CT scan differently, but then the differentiation part would be lost. And subsequently in this patient, there would be a development of, yes, I can pick up that hypodensity in my screen also. Yes, here, this is the hypodensity that would be developing, though that hypodensity will be taking some time to occur. The hypodensity will take like approximately 6 hours to appear. So there's a possibility that the CT scan can be normal also. The clinical presentation in this case will be classical, like diabetics patient, diabetes and hypertension patient is having a sudden onset face deviation and arm weakness for the last 3 hours and a dense MCA sign is present. The investigational choice in this condition would be a non-contrast CT head. But because CT head in the patient can be normal also, if the patient will come early, the CT scan will be normal. So in those circumstances, early detection of acute ischemic stroke, can be done with help of diffusion weighted MRI. The most common cause for acute ischemic stroke is atrial fibrillation, that is non-valvular atrial fibrillation. Very good. CT scan is done primarily because you want to rule out hemorrhagic stroke. The window period for management of stroke would be 6 hours. A large number of questions will be testing your knowledge with respect to acute stroke consultation. So always answer first for assessing of airway. It is ABC, it is airway, BP, and it is not breathing. It is airway, blood pressure, and clearly establish the time the last patient was seen normal, because you want to establish the window period with respect to management. You want to establish the window period with respect to management. Guys, it is ABC, it is airway, then it is blood pressure checking, because thrombolysis is contraindicated. If the systolic BP is more than 185 by 110, if the BP is higher than this, I'll try to lower it. Like in hemorrhagic stroke, the threshold was 220 by 130. Here, the intervention would be at 185, and the NIHSS score value should be more than 5. Then the person is eligible for endovascular therapy, or it is treatment with thrombolysis with IVPA or tenecteplase. Any of the drugs can be used. Alteplase or tenecteplase can be used. The final summary is within 6 hours, if patient will come. Though in the revised guidelines, they are saying in all cases of large vessel stroke, we should be going ahead with the endovascular therapy, that is straight away remove the clot from the brain blood vessel. But for the first 6 hours, in a case of acute ischemic stroke, in TIA, we do not thrombolyze, doctor. In the TIA, we do not do thrombolysis. In the first 6 hours, what we do in the patient is we have to thrombolyze. So in this patient, like what the drug that can be used is like alteplase or tenecteplase as a molecule can be used. The objective is alteplase should be started within 6 hours. After giving alteplase, CT angiography can be repeated. CT angiography can be done. The CT angiography is to check for whether the patient is having an improvement or whether is not improving. So I mean, CT angiography can be done to confirm the resolution. Updated ही बता रहा हूँ ना. It is CT angiography that should be done. It is, हमें तो हैरिसन के हिसाब से आंसर करना ना, हैरिसन के हिसाब से आंसर करना है. आपको टेक्स्ट बुक के हिसाब से आंसर करना होता है. सो इफ इट इज एल्टाप्लेस, या यू कैन गिव एल्टाप्लेस भाई. उस टाइम पे मैं फर्क नहीं पड़ेगा मुझे उस टाइम पे तो ब्रेन को बचाना है ना, तो आई कैन यूज एल्टाप्लेस और टेनेक्टाप्लेस कैन बी यूज्ड इन अ पेशेंट, तो कोई दिक्कत ही नहीं है. तो CT angiography will help me in confirming the resolution in this particular case. If patient comes within 6 to 24 hours, then it is thrombectomy that would be done. The test to be done before this would be CT perfusion studies. And if it shows perfusion, if CT perfusion shows an adequate perfusion, then it is mechanical thrombectomy that would be done in a patient. This thrombectomy can be written as EVT, that is endovascular therapy. In endovascular therapy. TIA में तो बच्चे TIA में improvement occurs in 1 hour. TIA upper limit is 24 hours. लेकिन TIA में अगर resolution होना है तो resolution usually starts. Transient ischemic attack will not wait for 24 hours. Transient ischemic attack is said to be transient. Upper limit is complete resolution occurs in 24 hours. It may take for 36 hours also. It is not a guarantee that 24 hours. It may take 36 hours. If I am having weakness in my hand, it's not a guarantee now that only after 24 hours the weakness will completely resolve. I might say at 24 hours 80% improvement. At 36 I may say 100% improvement. But resolution starts within 1 hour. Lekin in a patient of stroke, there will be no improvement. It is always a progressive deterioration. So TIA is a cutoff for 24 hours. That's an artificial value. Stroke में कभी improvement नहीं होता है. अगर face weakness हो गया, 3 घंटे से weakness चल रहा है, तो वो TIA नहीं हो सकता ना. TIA होता तो improvement would have started. चाहे वो 10-15%, 20% improvement होता, gradually वो weakness हमें पता चल जाता within 1 hour only. Streptokinase is not used, doctor, for this, and the cost difference is very huge. Streptokinase is used in myocardial infarction. Here we don't use streptokinase. They are not FDA approved. There is only 2 alteplase and tenecteplase for management of this patient. So what we need to do in this patient is mainly handle the treatment, that is CT perfusion studies would be done. And can we do a CT angiography before L-Tapless in a patient? Then yeah, we can be doing. Like मैं इसको यहाँ पे ऐसे बोलता हूँ कि suppose वो बोलता है कि non contrast CT scan of the patient is normal, ऐसे CT scan normal है, तो अगर मेरे पास CT angiography का facility available है, I can be doing the CT angiography before and after also, na? I can do a CT because CT angiography will help me identify a large vessel occlusion, LVO. So I can be doing a CT angiography before, if facility is available, before giving LTAPLS and after giving LTAPLS to the patient. That is to see whether there is a success that as I have obtained or not. By success, I mean that there would be a reperfusion that is occurring in this patient. So the message here is that CT angiography can be done before doing a thrombolysis and after doing a thrombolysis to check for whether the patient has improved or not. यार अगर रीनल पेशेंट है तो डाई का डोज कम कर देंगे ना आयुष्मान, ऐसा तो कुछ नहीं है। अगर इमरजेंसी सिचुएशन है तो आप डाई का डोज कम कर दो ना। एक्यूट किडनी इंजरी तो है नहीं उसको, मोस्टली तो डायबिटिक्स होते हैं ना उनका सीकेडी में। और अगर उनको मान लो आप कहते हो कंट्रास्ट इंड्यूस नेफ्रोपैथी हो भी गया, तो कंट्रास्ट इंड्यूस नेफ्रोपैथी तो रिवर्सिबल होता है, उसमें तो हम एनसेटाइलसिस्टीन भी यूज करते हैं, उसमें तो हम यूरिनरी अल्कलाइजेशन भी यूज करते हैं। Even if I get a CIN and a contrast-induced nephropathy, I can still manage it, right? And I can use a lesser amount of dose that can be used in a patient. So most of the time, the eGFR of patient can be calculated, and based on that, the amount of dye that we can be giving to this patient can be relatively do. If the blockage is in the small branches, then how can we do endovascular therapy? Yeah, exactly. If it is gonna be endovascular therapy will not work in cases of, that is why no CT, that is why I was saying a CTP to be done to demonstrate favorable perfusion. If it is small vessel stroke, if it is a small vessel stroke and patient comes after 6 hours, then you cannot do a thrombectomy. Thrombectomy is only possible for large vessel occlusion. That is why I mentioned that CT perfusion study would let me know whether it is beneficial to the patient or not. I would not like to waste my energy on doing a thrombectomy in a patient who is having clots in the smaller chota wala blood vessels. Then it will not be working. So Manish, I hope that resolves your query that thrombectomy is not going to work for small vessel stroke. But if I'm already done a CTA and CTP in a patient, then I can see now whether I should be using the resource or not. तो बंदूक कब चलाना है, right? The learning from this is when should you fire is based on the interpretations that I'm mentioning at the moment before you for within the first 6 hours and 6 to 24 hours. For venous clot, it is if it is venous clot, then the finding will be different ना, then it is heparin that would be used. जैसे विमेन में तो वेनस क्लॉट होता है ना, सपोज वो बोलता है कि एक लेडी को एंटी फॉस्फोलिपिड एंटीबॉडी सिंड्रोम है, वो बोलता है एक लेडी को फैक्टर 5 लेडन म्यूटेशन है, कनेक्टिव टिश्यू डिसऑर्डर्स वाले जो पेशेंट्स होते हैं, या बोलता है कि एक लेडी है उसको बेचेट्स डिजीज है। सपोज अ क्वेश्चन इज गिवन ऑन कनेक्टिव टिश्यू डिसऑर्डर, एंटी फॉस्फोलिपिड एंटीबॉडी सिंड्रोम, SLE पेशेंट, फैक्टर 5 लेडन म्यूटेशन, एंड ही सेज कि इस पेशेंट को सब्सिक्वेंटली जब हमने सीटी स्कैन किया तो उसमें एम्प्टी डेल्टा वाला फीचर आ रहा है। जो एम्प्टी डेल्टा साइन आप पढ़ते हो, दैट इज कॉर्टिकल वेन थ्रोम्बोसिस। इन दैट सेरिब्रल वेन थ्रोम्बोसिस, आइडियली वी शुड नाउ बी डूइंग इज अ MR वेनोग्राफी in these patients. If it is empty delta sign in cortical vein thrombosis, I should be doing a MR vein and MR magnetic resonance venography, and then subsequently for management of these patients, what we will be using is heparin, or we can be using enoxaparin to a patient. So this is management of venous stroke, na? This that I mentioned is management of venous stroke, where we will be doing a MR venography in a patient. So I think Dr. Varshikar, your query is sorted. I mean, this is a question in the paper where he mentioned a lady with Behcet's disease, I think, and she has, because Behcet's में तो vasculitis है ना, Behcet's arteries को भी involve करता है, veins को भी involve करता है। Normally तो जो vasculitis होते हैं ना, they involve only the arteries. But one vasculitis that involves arteries also and veins also is Behcet's disease, or it's going to be anti-phospholipid antibody syndrome. That is where we will be using heparin for this patient. So I hope, doctor, the query of yours is sorted. But this was an interesting discussion, guys. I mean, this is half a page only, but we have concised the information into a very logical, reasonable step that would be done. जैसे वो कई बार सीधा बोलेगा CT scan is normal, next best investigation, next to be done. तो करना तो intervention क्या करेंगे? तो if he says what is intervention to be done, the intervention is obviously LTAPLS. But he says what imaging can be done subsequently if CT scan is normal, then I can do a CT angiography to demonstrate the presence of large vessel occlusion in a patient. MI में सबलिंगुअल नाइट्रोग्लिसरिन एस्प्रिन दे दो डॉक्टर साहब। नाइट्रोग्लिसरिन तो बीपी चेक करके देना होता है ना, तो अगर आपके घर पे बीपी मशीन नहीं है तो फिर नाइट्रेट्स नहीं दोगे ना आप, तो इट इज लाइक ओनली चुएबल। घर का ट्रीटमेंट दो ही है, एस्प्रिन एंड स्टैटिन। फिल इन द पॉकेट वही तो है कि भाई किसी को अगर ऑलरेडी हार्ट अटैक हो चुका है, लाइक सपोज समबडी इन योर रिलेटिव इज ऑलरेडी हैड अ हार्ट अटैक एंड दे से कि व्हाट कैन बी कीप एट होम, कि दोबारा हार्ट अटैक हो तो क्या करें, तो इट इज चुएबल एस्पिरिन, दैट डिस्पिरिन का जो गोली है, एंड इट इज अटोरवास्टैटिन दैट कैन बी केप्ट एट होम, दैट 80 मिलीग्राम वाला अटोरवास्टैटिन, एंड एस्पिरिन दैट 325 मिलीग्राम वाला, एंड दैट कैन हेल्प यू इन मैनेजिंग द पेशेंट मोर इफेक्टिवली। इट इज एस्पिरिन। पिल इन द पॉकेट का कंसेप्ट ये है, उनको जिनको ऑलरेडी हार्ट अटैक हो चुका है आप क्या एडवाइस दे सकते हो टू अ फैमिली मेंबर कि वे दोबारा हार्ट अटैक हो तो हॉस्पिटल जाने से पहले क्या करें? घर पे नाइट्रेट्स नहीं देने हैं, बिकॉज अब बीपी अगर फॉल करता है तो मैनेज नहीं कर पाओगे। सो इट इज एडवाइजेबल टू गिव नाइट्रेट्स इन द हॉस्पिटल ओनली, सबलिंगुअल नाइट्रोग्लिसरिन। बाकी वो बात अलग है यार, किसी को अनस्टेबल एंजाइना के बार बार अटैक्स होते हैं और बीपी स्टेबल रहता है, तो अनस्टेबल एंजाइना में बार बार अटैक्स होते हैं तो हम घर पे भी नाइट्रोग्लिसरिन का स्प्रे दिला देते हैं, तो वो केस टू केस है। बट लाइक आई सेड, डोंट गिव अ एडवाइस फॉर नाइट्रोग्लिसरिन रेगुलरली, लेकिन स्टैटिन और एस्पिरिन तो देना है बिफोर एज सून एज द पेशेंट रीचेज द हॉस्पिटल। ओके, नहीं यार, फ्री कंसल्टेशन नहीं करना है और वो बड़ा रिस्की होता है, तो ये तो आप लोग तो डॉक्टर लोग हो, तो मैं ये सब आपके साथ डिस्कस कर रहा हूँ। ऑर्डिनरी लोगों के साथ में तो हम लोग यही बोलेंगे ना कि वी ब्रिंग द पेशेंट टू द हॉस्पिटल, क्योंकि यू कैनॉट एक्सप्लेन द टेक्निकल इफ्स एंड द बट्स देयर। ओके गाइस। नहीं 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 नहीं, वो तो टीआईए में एस्पिरिन देना है ना, सिर्फ डॉक्टर साहब, सिर्फ एस्पिरिन देना है। ओके, नाउ वी विल स्टडी द कॉन्ट्राइंडिकेशंस फॉर थ्रोम्बोलाइसिस। Now we will study regarding contraindications to thrombolysis, which are always asked in the exam. So how to remember them? You can practice with me. The mnemonic for this is storm. You can write this with me in case you are like, at the moment in your room and you're listening to me at the moment. Right, storm is the mnemonic. Right, so it would be sustained BP elevation despite treatment. Mark my words there. Sustained BP elevation despite treatment, guys. If the BP is more than 185 by 110 despite treatment, that is when you are gonna be not doing thrombolysis in a patient, and what you can do is like endovascular therapy or a thrombectomy in that particular case. Then is bleeding diathesis. If a person is having a tendency for bleeding, so T alphabet is for bleeding diathesis. T alphabet is for bleeding diathesis, guys. That's an important aspect to remember. O is for gastrointestinal bleeding. O is for gastrointestinal bleeding, like he had a peptic ulcer bleeding 21 days ago or within the previous 3 weeks. If he's had a GI bleeding, then I would not like to ensure, like agar main treatment kar diya to GI bleeding will start again in the patient. Yes. This is INR, very good pointer. INR more than 1.7. I am doing the practice of making it writing it before you ताकि अब याद कर पाओ ना. That is, next point is like, I don't think so anybody mistakes, because recent head injury means bleeding, or intracerebral hemorrhage also means bleeding, so that can be solved out. And then can be recent myocardial infarction also for recent major surgery. However, you need to remember 14 days for GI bleeding. You need to remember this would be 21 days. So try to remember at least one of them. Storm is a mnemonic that helps you rule out the contraindications for thrombolysis, and lot of questions would be having these contraindications also that you need to remember. So, and this is a diagram that is showing regarding that EVT, that endovascular therapy that I was talking about. Somebody was asking regarding ABCD2 score, so we'll do that also. In ABCD2 score, guys, we will be using it. I mean, why? The question in NEET was, why do you use ABCD2 score? So ABCD2 score is primarily used to basically evaluate the future risk or development of stroke in an individual. ABCD2 score is used to calculate percentage of chances. Very good, very good. It is used to calculate the percentage of chances of stroke occurrence in a patient. Alphabet A would be standing for age more than 60 years. B is for blood pressure more than 140 by 90. Then is clinical features of unilateral weakness, which is given 2 points. Remember that. Duration D more than 60 minutes is 2 points. If it is lesser than that, then the chances of resolution will be more. And why we call it D2 is because duration is also there and diabetes mellitus is also there. So age, BP, clinical feature, duration and diabetes is the ABCD2 score that we use for evaluation of these patients, and it is used to calculate the percentage of chances of stroke in a patient. And in all cases of TIA, what is the treatment that we'll be giving to the patient on an immediate basis? It is aspirin and atorvastatin to देना ही देना इन patients में. बट बेस्ड ऑन इकोकार्डियोग्राफी रिपोर्ट, अगर इकोकार्डियोग्राफी में पर्सन में लेफ्ट एट्रल अपेंडेज में क्लॉट्स आते हैं, in left atrial appendage, there is clots present, then any of the two treatments would be started, that is apixaban or warfarin. If it is non-valvular atrial fibrillation, then it is apixaban. If it is valvular atrial fibrillation, it is warfarin that would be used. So these are like A's that are used for management of transient ischemic attack: aspirin, atorvastatin, and apixaban. And depending on the situation, you might have to answer this accordingly. The highest chances of transient ischemic attack getting converted into stroke is 48 hours. मार्क माई वर्ड्स देयर, मैंने यहाँ पे काफी कट ऑफ्स बोले हैं. एक तो मैंने बोला कि टीआईए में यूजुअली स्पॉन्टेनियस इंप्रूवमेंट होती है, स्ट्रोक में कभी इंप्रूवमेंट नहीं होती है. टीआईए में स्पॉन्टेनियस इंप्रूवमेंट होती है, वो यूजुअली फर्स्ट आवर में ही इंप्रूवमेंट चालू हो जाती है. अगर इंप्रूवमेंट होनी है ना तो वो फर्स्ट आवर में ही स्टार्ट हो जाएगी. If he says what is the cutoff for transient ischemic attack, it is 24 hours. And if he says chances of conversion into stroke are highest, in then answer is 48 hours. Three values to be remembered: 1 hour, 24 hour, and 48 hours. Spontaneous improvement begins within usually first hour. What is the cutoff with which the symptoms will improve substantially? 24 hours. It can be 26 also. It can be 28 also. Like suppose somebody had weakness in the hand, then that weakness can improve by 90% in like 24 hours. Then maybe by 28 hours it will be 95%, and maybe at 36 hours it can be 100%. So this is just an artificial cutoff. Don't answer on the basis of whether, if symptoms are worsening, it is stroke. If symptoms are persisting, it is stroke. If they're worsening, they're persisting, it is stroke. If they're improving, it is transient ischemic attack. This was a FMG exam question. He said patients के symptoms improved over 36 hours. और बोला कि डायग्नोसिस क्या, तो स्ट्रोक नहीं है भाई. वो भाई धीरे धीरे इंप्रूवमेंट हो गया ना यार. स्ट्रोक में थोड़ी ना इंप्रूवमेंट हो जाता है कि फेस डिविएशन हो गया, बाजू में वीकनेस आ गई, लेग में वीकनेस आ गई, तो 24 बाद चलना थोड़ी ना शुरू कर देगा स्ट्रोक वाला पेशेंट. टीआईए कैन इंप्रूव, नॉट अ स्ट्रोक पेशेंट. उसने बोला पेशेंट इंप्रूव्ड ग्रेजुअली ओवर नेक्स्ट 36 आवर्स. एंड व्हाट इज द डायग्नोसिस ऑफ द पेशेंट? मोस्ट पीपल आंसर्ड इट एज कार्डियोएम्बोलिज्म और स्ट्रोक. नो गाइस, इंप्रूवमेंट इज अकरिंग, इट हैज टू बी अ ट्रांजिएंट इश्केमिक अटैक. इट इज नॉट अ गारंटी ना. इंप्रूवमेंट विल अकर एट 24 आवर्स ओनली. It can be gradual, and then subsequently the improvement will peak in a patient. अभी तो राइंड वाला कॉन्सेप्ट बोलते नहीं ना बुक में. अभी तो इट इज ओनली टीआईए एंड स्ट्रोक डिफरेंशिएशन दैट आर यूज्ड. नो, ओके, फाइन, फाइन. Mortality chances, doctor, in AIS the chances of mortality will be less. In hemorrhagic stroke the mortality is higher. That is mainly because of the fact that the blood pressure has not been controlled adequately. And now like we are aggressively managing blood pressure, so chances of survival will very much be there. Venous stroke has excellent prognosis. Like in women with connective tissue disorder, venous stroke excellent prognosis with complete functional recovery can be seen. Acute ischemic stroke, again improvement will occur if you are going to do thrombolysis or MRSI or thrombectomy in a patient in the limited time frame. Hemorrhagic stroke has a bad prognosis, especially if it is lower down, cerebellum, brainstem वाले एरिया में अगर bleed है, then bad prognosis. Lobar hemorrhage, still chances of survival would be much more. 24 hours, doctor. In ischemic stroke, it is not initially, like because we are doing thrombolysis now, so initially after 24 hours, like I think this was a question again, when can you start aspirin in a patient of ischemic stroke? It is after 24 hours. Initially, like because I have given thrombolysis, so I would not like to give anticoagulants to the patient. 5:30 वाले सेशन का करते. चलो यार इसको तो खत्म करो, ये अगले वाले जो क्वेश्चन है इजी इजी से क्वेश्चन है. यस गाइस, आई वांट एवरीबॉडी टू हिट द कमेंट बॉक्स इररिस्पेक्टिव व्हाटएवर इज योर स्टेटस. ब्लड शुगर माइन इज आल्सो लो, बट आई विल ग्रेजुअली ब्रिंग इट बैक. एग्जाम में भी तो यही होगा यार, 2.5 घंटे के बाद में ना एनर्जी खत्म हो जाती है. 2.5 नहीं, अब तो ज्यादा हो गए. यस गाइस, चलो मैं टाइम बोल दूंगा गाइस. 5 वुड बी टू अर्ली. आई थिंक 5:30 करेंगे. ओके. Seizures in a patient, more than 5 minutes in a patient of JTCS. Yes guys, quick answers, fast firing guys. What is the drug of choice in this particular case? Anshika was the first one to hit the trigger. Yes guys, remaining people, I'm still waiting for the chat to come up. Yes, Anshuman, I love the spirit man. Yes, here the answer would be given as IV lorazepam because this is a case of GCSE. So we will not be answering it as valproate. It is IV lorazepam that would be given in this patient, or we can give diazepam also. For focal seizures, it is carbamazepine. Ketone. Seizures is sodium valproate. Keep commenting guys, keep commenting. I want you to keep on hitting the comment button for all the drugs and type faster than writing that I am doing. Valproate is the common answer for GTCS, myoclonic seizures, atonic seizures, and focal seizures is carbamazepine. For focal seizures, I'll go into two. Okay, so I hope everybody has done the commenting till valproate. What is the best drug for prevention of febrile seizures? Options are oral diazepam, rectal diazepam. Quickly answer prevention. Prevention is to be answered. What is the best drug? One is oral diazepam, second is rectal diazepam to be given. Quick answers, please. Okay. For prevention, it is oral. It is not. It is not rectal. It is oral diazepam that is to be given. Ideally, the answer would be given as oral clobazam. In lot of pharmacology MCQs, that oral clobazam is not given. Then your answer would be given as oral diazepam. And if he says, how do you treat the episode? Then it is rectal diazepam. But then rectal can be a little messy. So it is intranasal midazolam. It is intranasal midazolam that would be used. Otherwise, it is rectal diazepam that would be used. Yes, yes, rectal in episode. Absolutely, absolutely. You guys are getting it right. Okay, drug of choice for absence seizures would be answered as ethosuximide, especially considering that this would be seen in babies, where the special EEG finding would be 3 per second, spike and slow wave pattern. Quick comments in the chat box. In which condition in the EEG do you get 4 to 6 hertz polyspike pattern? In which condition do you get periodic sharp wave complexes in the EEG? In which condition would you be getting? Keep on commenting, guys. I'll keep on giving the answers. Periodic lateralized epileptiform discharge. Flood. Periodic lateralized epileptiform discharges. Then is Rademacher complex. Waiting for your answers. Great. 4 to 6 hertz is juvenile myoclonic epilepsy, which is also called as Jan syndrome, where they can be future convergent to GTCS. Periodic sharp wave complexes would be seen with variant Creutzfeldt-Jakob disease. Periodic lateralized epileptiform discharges would be seen with herpes simplex encephalitis, where we use empirical acyclovir for management. Rademacher complex is used for Rademacher. किसी ने नहीं बोला. Okay, Sanskar was there to answer SSPE, that is subacute sclerosing panencephalitis. I've just tried to summarize a couple of important EEG findings that can be present, including the word triphasic waves. Yes, guys, triphasic waves, please. Conditions where you read triphasic waves in EEG. Waiting. Triphasic waves. Yes, hepatic encephalopathy. Second answer, please. Apart from hepatic encephalopathy, we also get it in variant Creutzfeldt-Jakob disease. The last entry here is the most peculiar one, where we get a grossly chaotic pattern, which is called as hips arrhythmia. Because traditionally the word arrhythmia rhymes with cardiology, but if I say the word hips arrhythmia, I'll write that once again. If I say the word hips arrhythmia, then that would be for Salam seizures. That is also called as West syndrome, in which we use ACTH and we use vigabatrin for management of the patient. I had excellent responses from you guys, so just keep it up and keep the spirit up. I mean, this is what I want, quick answers for the common scenarios that we have quickly revised here for the epilepsy component. We will look at Myasthenia Gravis. I think everybody knows Amitabh Bachchan, legend, right? Amitabh Bachchan in 1982 was shooting for that movie Coolie, when he got hurt and he had required emergency surgery, and he got infected blood transfusion, and later on it was detected that he was having hepatitis B. I mean, the diagnosis was made when we had, like, he had 50% liver damage, 50% liver damage. So Amitabh Bachchan, sir, legend that he is, he did not hide his hepatitis B status. He let people be knowing it, and that is why Amitabh Bachchan was made the global ambassador for goodwill ambassador for hepatitis B foundation. So one Amitabh Bachchan, I mean, he's like 85 plus, I think, at the moment, and he's still recording, still shooting. I mean, hats off to his dedication. He does like shows, for 3.5 hours, 4 hours, stuff like that. हम तो अभी जल्दी से थक रहे हैं, right? But then Amitabh Bachchan, sir, he had hepatitis B. Then his liver was damaged because of it. And though, I mean, hepatitis B is self-containing, but it can cause liver damage. and then even like myasthenia gravis. नहीं 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 नहीं, let's not say that. I wish like legend है तो legend ही रहे. Okay जी, so myasthenia gravis will be having all the D's coming up, and the screening test for this condition would be answered as ICE-PAC test. सर दो ही याद करनी है आपको मेन, तो एक एंटी, चलो करते हैं ICE-PAC test is the screening test for this condition. The investigation choice for this answer would be single fiber electromyography. It is a SFEMG. Apart from anti-acetylcholine receptor antibody, it is anti-Musk antibody, Elon Musk wala and then anti-LRP. Three antibodies that I would like you to remember for this condition. The most specific one is anti-acetylcholine receptor. The second is anti-muscle specific kinase antibody, and the third antibody is called as anti-LRP antibody. Lipoprotein receptor protein antibody, LRP. Three antibodies seen here. Most specific one is anti-acetylcholine receptor antibody. Treatment of choice for this condition would be answered as thymectomy. Decremental response बच्चे is the answer for repetitive nerve stimulation. Repetitive nerve stimulation के लिए जो finding आता है, that is what is called as decremental response. The treatment that we do is obviously with pyridostigmine and neostigmine, that I would not like to go into, but for generalized variety state thymectomy, and then the same thing in the same spirit you need to remember, thymectomy is not required for or is contraindicated in ocular variety of myasthenia gravis. There are fingers, Lambert-Eaton syndrome, incremental response. चलो मुझे बताओ, repetitive nerve stimulation में incremental response is seen in which condition apart from Lambert-Eaton syndrome? कोई comments in the chat box? Repetitive nerve stimulation, incremental response is seen in Lambert-Eaton syndrome, which is seen with lung cancer where there is a pre-junctional defect. Which other medical condition have you read where you get a incremental response on repetitive nerve stimulation? This person ate meat which was rotten meat, and there was entry of some spores in the intestine which affect the neuromuscular junction and caused a decrease of acetylcholine production. चलो rotten meat, rotten बोल रहा हूँ, that's not variant Creutzfeldt Jakob disease. Variant Creutzfeldt Jakob disease tainted meat. चलो अलग से बोलता हूँ, a baby was given honey. अब तो बोल दो, baby was given honey after birth, और honey के बाद में वो floppy baby बन गया, and there was a pre-junctional defect present. Very good. Botulinism. Rotten meat, because जैसे अभी गर्मी ज़्यादा है ना, तो जैसे मटन हो गया, चिकन हो गया, वो डिशेस खराब हो जाते हैं. तो अगर किसी ने सड़ा हुआ मटन खा लिया, सड़ा हुआ चिकन खा लिया, तो बोटुलिनिज्म हो सकता है, फूड पॉइजनिंग वाला ना, और प्री-जंक्शनल डिफेक्ट से उसको पैरालिसिस हो सकता है. तो वन इज लाइक इन अ country like ours जहाँ पे fresh, मतलब non-veg food should always be fresh, never like most of these restaurants etc they don't take good hygiene, so be careful about your health because summers is gonna be extreme in a country, और अभी तुम्हारे एग्जाम है, तो मेरे हिसाब से तो like you have to be very particular about your gut health and stuff like that. And anyway I got very good answers here, and a word of caution, हमें non-veg जब भी order करो तो from a better place, good place, and not from like these local places. या बटर चिकन तो खैर है ही है, मुझे बोलना था. चलो जी फाइन. लास्ट में जो लास्ट स्टेटमेंट है, लास्ट स्लाइड है आज के लिए, दैट इज फॉर गुलियन-बारे सिंड्रोम, दो स्पोकन अबाउट इट अर्लियर. दैट इज फेम is for remembering that this particular person would be having like infection initially in the form of food poisoning with Campylobacter jejuni or E. coli, or it's gonna be hepatitis E virus. This is itself a question of a paper, guys. What is the extra hepatic manifestation of hepatitis E? It is Guillain-Barré syndrome. What is the extra hepatic manifestation of hepatitis E? It is Guillain-Barré syndrome. Then can be Zika virus, which is responsible. Yeah, food preferences are like different for everybody यार, वो depend करता है ना, बचपन से जिसने जैसा खाया है उसके हिसाब से ही कहता है. Okay. So in Guillain-Barré syndrome, guys, it is a flaccid weakness that would be present, and there would this flaccid weakness would be associated with areflexia, and this areflexia will always be having a ascending paralysis. That is, paralysis will start from the feet and then it will be going upwards and can cause diaphragmatic paralysis also. it would be monophasic illness. Monophasic would mean that the progression can be so fast that within 12 hours patient might be ventilator dependent, or like weakness in first week would be in the legs, then would be in the trunk, then would be in the arms of the patient. And then A alphabet can also be used to remember albuminocytological dissociation. That is that everything would be normal in the lumbar puncture, but only the proteins would be elevated. And I mean that fame mnemonic also helps you in identifying electrodiagnostic tests for this condition. And the electrodiagnostic test would be demyelination on a nerve conduction study. So the basically, like, yeah, Pune we discussed had cases of GBS because the water supply was contaminated, the water tanks were contaminated, the government supply, and electrodiagnostic studies. And it is intravenous immunoglobulins or plasma exchange that can be used. The question in last time's paper was plasma exchange is done in refractory GBS. That is not correct. Any of the two can be used, guys. The efficacy of the two is equal. The efficacy of the two is equal. The only thing is that we prefer intravenous immunoglobulins because of the ease of administration. The MCQ said select the correct options. All these options were there. One option was that we use plasmapheresis in refractory Guillain-Barré syndrome. That is not a correct treatment because plasma exchange is not a backup treatment. It is also primary treatment. If I'm working at a tertiary care, I have facility available, we can do plasma exchange also. So that is like one government that you basically need to remember. एंड डॉक्टर साहब आजकल कमेंट्स वगैरह ज़्यादा ध्यान से लिखने हैं, पता चला है आजकल, है ना, खासकर अगर I'll not, let's not do that, doc, let's not do that, right? I mean, unnecessarily people will take snapshots of it and post and stuff like that. So why we doctors get into this? So my advice would be careful because unnecessary controversies can occur. Okay, so let's keep stay off it, but I'm happy that you guys are aware. Doctors should be aware of politics. Doctors should be aware of everything that is going on. I'm totally with you, but then we should be careful regarding what we post, especially as doctors there, right? So I think it's very, very important. So guys, we're done for session 1 at the moment, and आजकल डर का माहौल है भाई, ठीक है. तो we are done with the session number 1, guys. I enjoyed working out with you guys. 3.5 hours of solid session. That is what I want you to train up for. And like, in fact, I want you to do multiple such sessions every single day so that you are mentally capable of handling everything that comes. And they throw bricks at you in the paper and you say, bye, for then I kuch nahi farak padta, right? I mean, I want you to be bricks of steel, right? I want your mental stamina to go up on an every daily basis. I know you guys are very intelligent people, but then physical part also comes in that, in a sense that our ability to sit for 3.5 hours has to be there, and we have to continue with the same energy and the same enthusiasm in the first minute of the exam and the last minute of the exam. That would be my advice for you guys at this moment. So we'll see you in the evening, guys. Second session, guys, we'll reschedule for 5:30 because I think that all of us will need a little of break. So instead of 5 o'clock, guys, it's gonna be 5:30 that will be starting. And my suggestion to you guys would be that the GT test is gonna be live on very soon on PrepLadder from 23rd to 27th April. Irrespective कोई भी एग्जाम आप दे रहे हो, FMG दे रहे हो, नीट पीजी दे रहे हो, यार डरना क्यों एग्जाम से? आप कह रहे हो एग्जाम देना बेनिफिशियल होगा. I mean, मैं बोलूंगा यार ये सवाल ही सही नहीं है, राइट? आई मीन इट्स नॉट अ क्वेश्चन विच इज वैलिड. आपके सारे क्वेश्चन सही हैं, पर ये बोल रहा हूँ आज ये वाला क्वेश्चन वैलिड नहीं है, क्योंकि एग्जाम देने से यार हम ज्यादा टफ बनते हैं. एग्जाम देने से हमें एटीट्यूड और ज्यादा मिलता है. तो आप दो ना पेपर को, आप जल्दी कर लेना, आप टाइम कम लगा लेना, बट देन द मोर यू गिव पेपर्स, मोर यू आर एबल टू अटेम्प्ट. बिकॉज मेरी पहली लाइन याद रखना, एवरी क्वेश्चन यू सॉल्व इज वन स्टेप क्लोजर टू विक्ट्री. वी आर सॉर्टेड फॉर दिस सेशन, गाइज. थैंक यू सो मच फॉर ज्वाइनिंग विद मी फॉर दिस लॉन्ग. एंड नहीं, not butter chicken, it will be vegetarian. Chalo, take care, God bless you guys, and see you again at 5:30 onwards.